Hello and welcome to WHO Colorectal Cancer Screening Committee's second virtual plenary meeting. Without further ado, I'm handing over to North America Co-Chair Rocky Schoen.
Thank you, and welcome to everybody to WEO's 2021 plenary session in conjunction with DDW. It is great to have you with us. Of course, we are on Zoom, and that has some advantages and some disadvantages. The good is that all of us can join from all over the world, and it's a lot easier than traveling to, say, San Diego. On the other hand, we have to recognize some limitations. Our Asia Pacific partners, and in Australia, it is very late in the middle of the night, and they have to work tomorrow. And so we can't welcome them as we probably wished we could have were they here in person. I certainly hope, I should also mention that Zoom is not as good for human interaction and talking with each other and really questioning back and forth. But I hope that next year we will be in person and perhaps with Zoom as well, and we'll be able to have both. I want to remind you all that the WEO program is what I call an investigator-initiated program. That is, you make the suggestions and we try to filter them through and create a program. And so this is really your program, and it is my pleasure to welcome you to it. I finally want to acknowledge the great strides that WEO has made in the last years. Of course, the organization has been around a long time, but we owe a tremendous debt of gratitude to Graham Young, who really spurred the screening program and the screening prevention committee. That was followed by tremendous work by Linda Rabinek, and now we are under the great pleasure of having Evelien Dekker as our chair to take us to yet greater heights. With that, I would like to move to the housekeeping slide to remind you that you may post your questions in the Q&A box. At the end of every session, we have time for Q&A. The Zoom's chat function is not functioning. Q&A is the where to do it, and we will have short breaks after every session. So with that, I'd like to turn over the program to Hanmo Chu from Taiwan and Roque Science from Chile.
Thank you, Rocky. So first of all, I would like to welcome all of you to participate in today's WHO Colorectal Cancer Screening Committee virtual meeting. And I'm very happy and very excited to chair the first session with my co-chair, Professor Roque Science. So we have a very exciting agenda today. In the first session, we are very happy to have 4 speakers presenting about the impact of COVID-19 on colorectal cancer screening and the risk stratification in colorectal cancer screening. So may I introduce the first speaker, Professor Ken Fair. Professor Ken Fair is the director of the Dekker Center and the professor of the University of Sydney. She has led evaluation of new cancer screening approaches for government agencies in several countries, including the COMPASS, which is the first major international experience of cervical screening in an HPV vaccinated population, and take the leadership in national cervical screening program in Australia from Pap smear to 5-yearly HPV-based screening, and the WHO Cervical Cancer Elimination Modeling Consortium. Welcome, Professor Ken Fair.
Thank you very much. It's a real pleasure to be here, and I'd like to thank the organisers for the honour of the invitation to speak. I am speaking, as you heard, as an epidemiologist and modeller and as someone who works across screening programs, but I'm really speaking on behalf of a large group of people who have been involved in the COVID and Cancer Global Modelling Consortium. And my topic today is the effect of COVID-19 on colorectal cancer screening. I really want to, take a modelling lens to this presentation and try to convey some of the insights that modelling can give us in this space. So the COVID and Cancer Global Modelling Consortium, that is CCGMC, aims to configure modelling platforms and to estimate the potential impact of COVID-19 on cancer across a range of outcomes. And I just want to acknowledge all the many individuals who have participated in this work, and also the institutional partners, the UICC, the International Agency for Research on Cancer, the Canadian Partnership Against Cancer, the International Cancer Screening Network, and the Daffodil Centre at the University of Sydney. So the CCGMC, just to give you the top level view of what we're doing, we're actually working at quite a broad level to look at all the types of impacts that the crisis can have on cancer outcomes. So from the effects on survival itself, either a direct impact of the infection, a direct biological impact of the infection in cancer patients. Also, of course, the indirect impact of health services, disruptions to cancer treatment is one of our focus areas. And we're also looking at the direct or indirect impact on cancer outcomes resulting from changes in comorbidities. We're also looking at changes in cancer risk and prevention. So again, the direct impact on cancer risk of the infection, but also the effect on risky behaviours such as smoking and alcohol exposure during the crisis will have a long-term effect on many cancers, potentially, of course, including colorectal cancer, and has an impact on primary prevention programs directly. But most germane to our discussion today, our concern has been around also disruptions to screening programs and delays in symptomatic presentation. So in terms of the work that we're doing in colorectal cancer screening, we have had several aims. So firstly, our first aim has been to harness established and validated microsimulation modelling platforms, and I'll explain that term in a minute, in countries for which these have been developed and are available. And our aim there is to simulate both the short and long-term impact of CRC disruptions on cancer incidence and mortality, considering a number of scenarios for disruption, extent and duration. And then to set up these platforms so that as more detailed real-world data on disruptions becomes available, that we can dynamically incorporate such information to update our model predictions. Secondly, we have aimed from the beginning to evaluate the effectiveness and indeed, as appropriate, the cost effectiveness of potential recovery strategies, considering situations, firstly, in the first instance, where resources and capacity to enable catch-up in screening programs are unconstrained, but obviously recognising that that is often an unrealistic assumption. So we're also starting to look at situations where prioritisation decisions, where tough decisions need to be made, either for screening or referrals to colonoscopy. And then finally, and I won't talk about this today, but our aim is to use these results from specific individual countries to inform what's currently being developed, a responsive multi-country platform which uses the detailed modelling in a few countries to inform pre-disruption screening modelling for countries with similar programs, and to combine this with country-level burden of disease information and emergent disruption information to give us a very flexible tool that can enable many countries to tap into the insights that the modelling can give us. So just very quickly, this is an example of a microsimulation model. This particular illustration is of the Policy 1 BAL model, which we use in our team in Sydney. And this was developed in collaboration with Dr. Fele Coupe from VU University Medical Centre in the Netherlands. So as for the other models used in the study, Policy 1 BAL is a microsimulation model. And the key aspect here is that it models colorectal cancer natural history with an overlay of cancer screening. So this particular model incorporates two biological pathways, the adenoma carcinoma pathway and the serrated pathway to colorectal cancer development. And as for other models of this type, it simulates millions of individuals. So we're literally simulating at an individual level in the population. And each individual is assumed to start with normal mucosa, but then can have a risk of developing one or more lesions, which then have the potential to progress to cancer. And there is this overlay of detailed screening, referral and surveillance pathways for each model. And each model is calibrated to detailed outcome data on colorectal cancer incidence and mortality in a local setting, and taps into much local data about screening in country. So for our initial analysis, we performed a 3-country 4-model initial comparative analysis using the OncoSim platform in Canada. In the Netherlands, we were lucky enough to be able to work with two groups who had two different platforms, ASCA from VUMC and MiScan Colon from Erasmus University. And in Australia, the Policy One Bowel platform. Now, the screening programs have many commonalities across the countries. All of them offer biennial fit testing from the age of 50 or 55 to the age of 74 or 75. Participation is quite different, with notably higher participation of over 73% assumed for the Netherlands pre-pandemic. The COVID-19 situation is a little different in each country, but in each country, there was some impact in the immediate aftermath of the crisis. So in both Canada and the Netherlands, there was a program pause after March 2020. In the Australian context, there wasn't an explicit program pause, but as in the Netherlands, we did see a drop in colonoscopy of over 50% in the few months after March 2020. So as part of the CCGMC work, our 4 groups came together and to date have conducted 2 different analyses, which I'll quickly take you through. So one of our challenges actually has been in obtaining detailed data on real-world disruptions. So in the first instance, we were forced to use a number of standardized disruption scenarios across countries, but this nevertheless really helps us characterize the impact of either past or future disruptions, which unfortunately, of course, we need to think about. And so this figure illustrates our approach to modelling hypothetical disruptions to screening. The disruption period itself can last for a given number of months. And there's the possibility that in the immediate aftermath, we could either provide catch-up screening, which is one of our main recovery strategies, or that there would indeed be the potential for a lower level of screening participation and potential loss of confidence in the program. So both of those alternate scenarios were modelled. In the base case, in our first analysis, we assumed a 6-month disruption in 2020 and no catch-up or changes to participation. And our comparator for the analyses was no disruption. So the ongoing screening program continuation was the comparator, assuming the counterfactual of no disruption. So this slide shows the projected changes in colorectal cancer incidence in those aged 50 and over relative to no disruption across the 3 countries and the 4 models. So you can see here MiScan Colon, ASCA, Policy One Bowel, and OncoSim results. And the key take home here is that in the base case, all models predicted a short-term decrease in diagnoses, as you'd expect with the disruptions to screening. And the extent of this was of the order of 12 to 13% in the Netherlands, around 9% in Australia, and around 7% in Canada. And you see these very similar patterns and effects across all models and all countries. And importantly, this decrease in colorectal cancer diagnoses, which would be seen and expected in 2020 from the disruptions, is predicted to be followed by a corresponding, unfortunately, peak in colorectal cancer incidence in all 4 models in 2022, if disruptions aren't sustained beyond 2020. And that this would be followed by a sustained increase, which would last for a decade or more in each country. And so one of the important messages here is that the effects, even of a short-term disruption, will be quite long-standing unless strategies are taken to catch up. And this slide here illustrates the beneficial impact of catch-up strategies. So on the left, we have the short-term drop in colorectal cancer diagnoses in 2020, in the blue without catch-up and in the yellow with catch-up. And on the right, we have the additional long-term diagnoses and deaths, again, showing the results for blue, no catch-up, and yellow with catch-up. And the key message here is that if we can instigate rapid catch-up scenarios, the short-term drop in diagnoses can be halved, and this largely ameliorates the long-term impact on additional diagnoses and deaths as well. And again, there's this general consistency across all 3 models and all 3 countries and 4 models with this picture. And in this paper, which was published at the end of last year, led by Lucy de Jong and Iris Lansdorp from Erasmus, we really highlighted what we saw as a very clear policy message that CRC screening should be continued to whatever extent it is safe, but where suspensions are necessary, catch-up screening can mitigate, although not entirely remove, the risk of increased colorectal cancer incidence long-term. And very quickly, we've also started to look at consideration of prioritised referrals to colonoscopy. And in this main analysis, we've really started to think about potential actions in a more realistic resource-constrained setting. So here I'm showing some preliminary results from this analysis, which is using one of the models, Policy 1BAL in Australia, again, to illustrate the effects. In this case, we assumed the disruption period was 3 months with varying recovery periods. So you see the results shown for 6, 12 and 24-month recovery periods. And we actually looked in this case at the possibility of increasing the fit threshold to prioritise referrals. So in this particular graph, you can see on the left the monthly change in colonoscopy demand during the recovery period that's required to perform the catch-up of screening. And a 0% change refers to the usual demand that would have been expected without the pandemic. And on the right, you can see the total number of excess colorectal cancer deaths in the period to 2050 that could be prevented by performing catch-up screening. So 100% prevented means that all the excess deaths are prevented. So really importantly, what we found is that when catch-up screening is performed at the regular threshold, so shown here now highlighted, almost all excess deaths due to the pandemic can be prevented, but you can see there's considerable additional colonoscopy demand required. So conversely, if there's limited capacity to increase colonoscopy services, the recovery period could be extended to 12 or 24 months while still preventing most excess deaths. But an alternative approach is that if you cannot increase the usual colonoscopy demand, the fit threshold could be increased to prioritise referrals. And here we see the possibility that at least 50% of the excess deaths could still be prevented even without increasing the colonoscopies by increasing the fit threshold to prioritise referrals. And for the other models that did this exercise, a similar result was seen. So we think this is a first of what we hope will be many evaluations of prioritised strategies for recovery. Just very briefly, I want to note as well that, of course, it's not only disruptions to screening, but also disruptions to colorectal cancer treatment that will be important. And just to note that the CCGMC ultimately intends to reflect the combined impact of both screening and treatment disruptions. And as a separate work stream, we're working to analyse data from SERVMARK, a registry database which gives us survival information conditioned by treatment delivery in high-income countries. And we're also heavily reliant on a very important meta-analysis by Tim Hanna and colleagues that looked at the mortality impacts due to cancer treatment delays that was published last year. So that will be coming as well. I also wanted to flag that the CCGMC is in the process of establishing a COVID and cancer observatory. And the idea here is to provide a living resource once we have these models up and running, where countries can log in and look at the most current predictions for outcomes in their setting, and that will reflect some of the prioritised recovery strategies that we will be evaluating. So in conclusion, I think modelling had already demonstrated its importance to pre-pandemic policy making, but I do think it's important to say that the crisis has really emphasised and hammered home, if you like, the importance of timely access to information on screening program data and metrics. And as these data become available, we will be using it hopefully in a real-time fashion to update and continually improve the model predictions. We found already that disruptions to colonoscopy referrals for screen-positive individuals could have a major impact, so novel prioritisation strategies for colonoscopy really do deserve consideration in countries. But a silver lining is that this actually changes the framing and might even accelerate consideration of implementing risk-based screening approaches, because of course prioritisation is another way of framing the question of how to actually prioritise either screening or referrals for those individuals at highest risk. And that certainly will be something that the next speaker, Dr. Lansdorp, will pick up on. So to finish, I just wanted to emphasize again our main finding to date. It's crucial that if disrupted, screening programs ensure participation rates return to previously observed rates and provide catch-up screening whenever possible, since this could mitigate the impact on colorectal cancer deaths. And I'd like to gratefully acknowledge all the many individuals and teams that have contributed to these findings within Working Group 2 of the CCGMC, particularly my co-chair, Iris Landstock-Boltegar, and the technical modelling team leads, Fele Coupe, Jean Young and Eleonora Filetto, as well as our own team members, including Yoa Worthington and Eleonora Filetto and Jabin Liu. Thank you very much.
Thank you very much for the wonderful presentation. So we have a discussion at the end of this session. So now I invite Professor Sang to introduce the next presentation.
Okay, I would like to remind the participants that we encourage the audience to submit questions via the question and answer box. And we go straight to the second topic today that is going to be presented by Professor Iris Landstrup-Vogelaar. And she is an associate professor at Erasmus University Medical Center, Rotterdam in the Netherlands. There she heads the research section on evaluation of screening for gastrointestinal disorders. She operates at the forefront of cancer screening worldwide, with her work directly influencing cancer screening recommendations for the BMG Rapid Recommendations Panel, American Cancer Society, and US Preventive Services Task Force. And she's going to talk in the next minutes about the risk stratified intervals for FIT screening. Professor Iris, please.
Thank you very much, and thank you very much for the opportunity to present to you today on risk stratified intervals for FIT screening. I have no conflicts to disclose, and I want to talk to you about the balance between benefits and harms. That's essentially what this presentation is all about. We try with screening to improve the benefits of screening. So we want to lower the mortality and the morbidity of certain diseases. But we have to realize that screening is also associated with harms such as false positive test results, complications, and overdiagnosis. And therefore, we should not think lightly of screening. And we have the continuous responsibility to try and improve that balance between harms and benefits. And one way that we could do that is by using personalization. If we look at what holds for mostly the current screening programs with FIT screening, every time, mostly every 2 years, let's say from every 1,000 individuals that we screen for colorectal cancer, actually 975 of those don't have any relative findings at the FIT screening. And so of those 975 that have no relevant findings at the FIT screening, there is one person that may develop an interval in between. There are about 24 persons that do have significant findings at the repeat FIT. But then again, there's 950 people who actually don't have any relevant findings at the repeat FIT either. And so every time we're burdening 975, 950 individuals that do not experience any benefit from that screening. And so ideally, we would not screen those individuals as quickly again. And yet the individuals that do have relevant findings or an interval cancer, you would have screened ideally a little bit earlier. And that's what personalization is about. Well, we do have a lot of possibilities for risk stratification in colorectal cancer screening. There are several individual risk factors that are available for colorectal cancer, such as sex, race and ethnicity, lifestyle, family history, but also the SNPs, the genetic information. And on top of those individual risk factors, actually several risk prediction models have been developed that combine those individual risk factors to try and predict those people that are at highest risk. And more recently, we also realized that actually screening history is an important predictor of future risk. So there are several possibilities here. But yet, if we then look at what has been going on, we've been talking about more personalized, more risk-based approach to colorectal cancer screening for more than 25 years already. Actually, it was David Lieberman at that time that introduced that thought. And still, it has nowhere, almost nowhere at least, been implemented. So what could be the potential reasons for this? Well, one, I think I'm just putting down my thoughts here. One important reason that I see is that many of the current risk prediction models require that there's an additional collection of data. And with the additional collection of data, there might be the problem that people stop participating in screening. And this way, if they don't want to provide that additional data and stop participating in screening, actually the benefits of risk stratified screening could be outweighed and could be foregone. Moreover, if we look at the current risk prediction models, their discriminatory accuracy is actually quite modest. We're talking about an area under the curve of about 63%. And if we look at the most sophisticated risk prediction model from this time, actually the top 1% people of highest risk only have an odds ratio of about 14 compared to those at lowest risk, which is of course quite a modest difference in risk for, again, a very small group. And finally, which may be the biggest hurdle against a more risk stratified approach to screening, is that it's quite complex. And because it's complex, people may get confused. And of course, confusion can also lead to a decrease in participation. And there's also the concern that maybe with a more complex program, people are not able to make an informed decision anymore to participate in screening. And then there's, of course, other more ethical concerns such as stigmatization and discrimination. So there's definitely still a few hurdles that we have to take. But maybe prior fecal hemoglobin concentration is the solution to at least some of these hurdles. The advantages of using prior fecal hemoglobin concentrations in FIT screening programs for risk-based screening is that, for one, in most organized programs, the fecal hemoglobin concentration is already being recorded and registered. So there's no need for additional data collection, taking away one hurdle. Also, and I'm going to show that in later slides, actually, the predictive performance of fecal hemoglobin concentration is very promising and is anticipated to further improve when we have more rounds of information available. And finally, maybe if individuals realize that their higher risk is not based on some individual characteristics, but is actually based on a test result, that might be more acceptable to that presentation for that population, and therefore may also result in less issues of stigmatization and discrimination. So this way, prior fecal hemoglobin concentration can take away some of these concerns. And as I said, the evidence is actually quite promising. What you see in this slide is already what happens after one single round of FIT screening, and these are results are quite old. It was actually the Taiwanese in 2011 that already showed that prior fecal hemoglobin concentration was an important predictor for future advanced neoplasia detection already in 2011. And if you look at the graph here, then you see that the difference in risk over time, where different lines represent a different fecal hemoglobin concentration in the first screening round, that you see that the people that had a fecal hemoglobin concentration exceeding the 100 nanogram per milliliters, and this is an older study, so we're still using the old nomenclature there, and you see that that risk is actually much higher than if you look at people that had no detectable hemoglobin at their first screening. And something very similar was shown in the Scottish program in the first round, where you look at what happened in the fecal hemoglobin presentation in the previous round. And if it was very low, then you see that the majority of individuals at the subsequent round actually have lower risk adenomas or nothing at all. Whereas if you go to the higher end of the spectrum towards the 80 microgram per gram feces hemoglobin, there you see that the majority of individuals actually had an advanced adenoma. So already after one round, we saw these promising results. After that, studies started looking at what happens if you have information about 2 consecutive rounds. And these are actually examples from 2 studies in the Netherlands and in Italy. And on the left hand, you see a panel from the pilot studies that were performed in the Netherlands. And if you look at individuals that are in the lower left corner, so that those are individuals that at 2 subsequent screens actually had no hemoglobin in their stool, and then look at what their risk is actually lower than 5%. Then if you look at individuals that scored just below the cutoff for 2 screens in a row, their risk is actually exceeding 40%. So a huge spread in risk. And Carlos Honore and his colleagues actually looked at the cumulative fecal hemoglobin concentration. So summing the 2 concentrations up, and you see a similar thing happening with a very low risk if your cumulative score was 0 microgram per gram feces, and a much higher risk if you look at scores that exceed, together at least, the threshold of 20 microgram per hemoglobin per gram feces. And if you translate those sort of results into an odds ratio, that's where we get to the study that was recently performed by Andrea Buron in Spain, then what you see is actually that the odds ratio of people that have a high negative fit value 2 times in a row, that they have an odds ratio of about 22 compared to the non-detectable hemoglobin 2 times in a row. So that's a much higher odds than the 14 that we saw before. And this was recently confirmed by my colleague Renier Meester in the FIT working group meeting that we had earlier these weeks. And he looked at what a single fit and what consecutive fits would add to the discriminatory performance. And what you see from this graph is that if you just look at a single fit, then the discriminatory performance is actually quite high. So it's still 72% area under the curve, compared with the 63% of the risk prediction model. That's quite good. But if you have 2 consecutive fits, what you actually see is that it increases from 72 to 78%, which means that it's even not just a statistically interesting addition, but also a clinically very impactful addition to risk prediction accuracy. So if we keep that in mind, it means that maybe if we have 1, 2, and 3 fits, or up to 11 rounds, as we have in the Netherlands, or in the US, there's even more, there's up to 30 rounds of fit screening, then you might get better and better in predicting who is at high risk and who is not. And one way we could explore this area is by using a more sophisticated statistical modeling technique, which is called multivariate joint models for individual risk prediction. And what this technique actually does is it takes multiple measurements of biomarkers over time, but it doesn't consider those measurements to be the truth. There is some measurement error in there, there is some randomness in the measurements, but what it takes is it sort of tries to estimate from those multiple measurements what the underlying risk profile is. And so you see that here, that you have the stars or the asterisks, which are the individual measurements, and then the green line is what the model estimates the true underlying risk to be. And then based on that estimated risks, makes predictions for what the future risk of, for example, in our case, colorectal cancer would be, and the disease-free survival over time, or the disease-free probabilities over time. And what you see here is if you take those multiple measurements, you cannot just take the final predicted value, but you can also take the increase over time to be your predictor, or you could even take the area under the curve over time to be your predictor. And this is one example, but the idea, of course, would be that you would have multiple measurements for different persons. So in this case, you would have a red person and a blue person. And then based on the measurements of biomarkers, you see that there would be very different estimates of risk for the blue person and the red person. And you could use these estimates of risk to determine what the next screening interval would be. So to conclude, we see, and I believe, that prior fecal hemoglobin concentration is a very promising means for risk stratified colorectal cancer screening. It has very good predictive performance, and it is anticipated to further improve when we have multiple rounds of screening available. And a very big pro of this measure is that there is no need for additional data collection. And I think that with this sort of gold in hand, it is time now to start performing studies and to address the other barriers that we know to be existing to risk stratified screening, so that finally we know how big these barriers are and we can start implementing it. And I think, as Karen already alluded to, that the COVID-19 has only shown us how important it is that we can do some risk stratification. So that's the silver lining to this. And I'm very glad to see that there are initiatives in the Netherlands, Italy, which will be presented on a little bit later, and Spain to try and start implementing risk stratified screening with FIT using prior fecal hemoglobin concentration. And with that, I want to thank you for your attention.
Thank you very much for the wonderful presentation. So now I introduce the third speaker, Professor Marco Zappa from Italy. Professor Zappa spent the majority of his professional life at the Institute for Study and the Prevention of Cancer, Scientific Institute of Tuscany region, where he directed the unit of clinical epidemiology. And since 2002 till 2020, he served as the coordinator of the Italian Center for Screening Monitoring, which was committed by Italian Ministry of Health. So today, Professor Zappa will be presenting the risk stratification for screening in the wake of COVID-19. Professor Zappa, please.
Thank you, Chairman. Thank you to the organizer. The aim of my presentation today is to discuss the approach of risk stratification in order to recover the delay caused by COVID-19. Now, if I, okay. Do you see my slide?
Perfectly, thank you.
Thank you. Okay, let's start from the problem. The problem is that due to the COVID-19 pandemic, we in Italy, as well in most of the European countries, we observe a dramatically decrease in the number of colorectal cancer screening tests performed. And the reduction was due, at least in Italy, to two factors. One is the disruption of colorectal program, and the total disruption in the first wave of COVID pandemic, and after that, a reduced activity. And the second factor is a decrease in adhesion to invitation from the people. These are two different factors that we have to take into account. In fact, in Italy, we observed in 2020, as compared to 2019, a decrease of 32% of a number of invitations, and a reduction of 45% in number of FIT tests performed. It means that approximately the participation to invitation decrease about of 20%. So the problem is how to recover the delay. I will start from a very general consideration. How to recover the delay depends in part from the forecast of the impact of COVID pandemic in the next future. Because if we consider that the greatest effect of COVID is almost over, we could accept that we have a screening interval longer than 2 years, the scheduled 2 years. Let's say a screening interval of 2 years and a half, 3 years. But thereafter, we can start again with a regular 2 years interval. A different situation, and is the situation we have in Italy at least, if the delay is still increasing, and in that case we have to do something. How we measure, how we have measured the delay in Italy, and we have compared the number of examination and the number of invitation in 2020 as compared to 2019. And we use this specific parameter, the standard months of delay, which means, and it is that the number of months required at a certain moment to be able to catch up, assuming the same average monthly productivity of 2019. So that is the result for Italy, and we can you can say that at the end of 2020 we had 5.5 standard months of delay. You can observe that also from October of December, the delay still increased because we had in that, as compared with the same period of 2019, an increasing delay of about 1 month, 1 additional month. And the second point to note is that we observe in the Italian region a large variability in results. That is a difficult point to afford, but in one region we do not have any delay at the end of 2020, and in some other the delay was huge. And the second point to consider is to find out what are the critical points of the program. For example, the critical points depends from kids from kids delivery, or depends from colonoscopy availability. Because the answers are different accordingly to what is the most important critical point. And in general, to recover the delay, we have 2 general options. One is to expand the resources dedicated to screening, but it's difficult to enroll skilled, if the delay depends from colonoscopy. It's difficult to enroll skilled workforce for colonoscopy in a short time. The other option is to select the population to invite and decide to prioritize invitation to people at higher risk. And so we are in the field of risk stratified screening. What is a risk stratified screening? A risk stratified screening is a screening where different protocol of screening are scheduled for subject according to their personal risk of having the disease. And from the point of view of the community, this kind of approach is beneficial, because it is a more efficient approach, because a positive predictive value of colonoscopy depends on the prevalence of disease. And so with a higher prevalence, we have a lower proportion of false positive. And consequently, the number of subjects referred to colonoscopy needed to find an advanced lesion will be lower. So the colonoscopy become more efficient. we can discuss the second point is also more fair because we select the people at higher risk. The criteria for selecting people at higher risk have been discussed also in the previous presentation. First of all, we can choose a subject with a recent positive fit, not followed by colonoscopy. This criterium in Italy was applied in the first phase of the COVID pandemic, and it was mandatory to perform colonoscopy in people with a positive fit. Other criteria could be to select people with a higher prevalence of disease, like males or older people, people not regularly attending a screening invitation, and finally also we can use to increase the threshold of fit positivity, and as mentioned before, use the cumulative fecal hemoglobin concentration over 2 previous consecutive fits. As in this figure from for all, it's clear that the number needed to scope, if we increase the threshold for positivity in fit, the number needed to scope in order to detect one advanced neoplastic lesion decrease, increasing the threshold. And as that is just mentioned before, is the paper by Carlos Senore, and where we observe, as previously described, that the sum of fecal hemoglobin in over the 2 previous exams are a good predictor of the risk of an interval cancer, and so we can, if we have to select, we have to reduce the number of colonoscopy, is preferable to choose people with a higher risk to have an interval cancer. That's the same. But there is also another point of view. I would like to finish with these remarks. That the first difficulty in applying a risk approach, a stratified risk approach, is that it's difficult to do it during the pandemic of COVID. That is difficult to be managed. And the second point is the fact that from the point of the single individual, of the single subject, it's not so easy to accept the fact that if I am in a position of to be at a lower risk, I have to skip or to delay my preventive exam, and that is particularly true for subject. For example, people regularly attending screening are at lower risk as compared to people attending not regular screening. But those subjects might feel abandoned by screening program if a risk stratified screening will be applied. So my final remark is if we decide to introduce criteria of a risk stratified screening, we have to prepare. We need a proper communication strategy in order to explain and clarify our decision. Otherwise, the disorientation of people will be increased. Thank you so much for your kind attention.
Thank you, Professor Sapa, for your wonderful presentation. We encourage the audience to submit questions via the question and answer box at the end of this next presentation. There's going to be about 10 or 20 or 12 minutes for questions. So our last presentation is from Dr. Patrick Boschwig, who is the professor of clinical epidemiology at the Amsterdam University Medical Center, where he leads the biomarker and test evaluation research program. The BITE program aims to appraise and develop methods for evaluating medical tests and biomarkers, and to apply these methods in relevant clinical studies. In doing so, the program wants to strengthen the evidence base for rational decision-making about the use of tests and testing strategies in healthcare. So the title of his presentation is Incorporating Demographic Algorithms to Improve EFAT Screening. Professor Patrick, please.
Thank you very much, Mr. Chairman. And thank you for the invitation to present here today and to follow up on the very clear presentations from Dr. Lansdorp and Dr. Zappa. Because I will be talking about including information about the demographics in the risk-based approach. And my take-home message is that by using different fit positivity thresholds based on demographic information, we could reuse some of the difference that exists in fit performance and restore equity and efficiency in colorectal cancer screening. I myself have been invited twice to the Dutch colorectal cancer population-based screening program. And that means on first-hand information, I know that the information has access to demographic information. They know my name, they know my age, otherwise I wouldn't be invited. They know my sex, because the letter was addressed to Mr. Patrick Boschwig, and they know my address. In this presentation, I don't want to focus on addresses, but I want to focus on the fact that they know my age and they know my sex, but they don't use it in the current program. I want to question whether that's reasonable. And in order to do so, I will use data from a population-based invitational screening pilot performed earlier in the Netherlands in over 1,100 participants. All had a screening colonoscopy and a one-sample FIT, but the FIT was not used to select people for colonoscopy. And I will be focusing on the detection of advanced neoplasia. Now, this is the age and sex distribution in this screening pilot where everybody had a colonoscopy and a one-sample FIT. And there was about a similar number of males and females, and I've grouped them here into age categories, around 50 to around 75, so categorized. And the first question is, how many people in this study had advanced neoplasia detected at colonoscopy? And there we see the usual difference between males and females. More males had advanced neoplasia detected at colonoscopy. And if we look at people classified by age, we see the usual pattern confirmed in other studies that the elderly had more advanced neoplasia detected than the young participants in this study group. Now I'm going to look at the use of FIT. What if we had selected people for colonoscopy based on the FIT results? Well, for doing so, we need a positivity threshold. And in this presentation, I'm going to focus on a relatively low positivity threshold of 10. If I had selected a higher threshold, there would be fewer positives, fewer false positives, and fewer true positives. And of course, if I had selected an even lower threshold, I would have selected more positives, true positives and false positives, but I'm going to focus on a selection, a positivity threshold of 10. So one size fits all positivity threshold, as is now used in most of the programs around the world. What does it mean for FIT positivity if classified by sex? Well, more males have a positive FIT result than females. And if we look at the results by age, we see the same pattern as before. More of the elderly have a positive FIT result than the younger participants in this study group. And there's a clear trend. You could say, well, that's reasonable because more males and more of the elderly have colorectal cancer. But I also wanted to look at the actual distribution of FIT results. Most of the participants had zero hemoglobin, so zero FIT results below the limit of detection. So that's not informative. So I want to focus on the third quartile, the point that separates the lower 75% from the upper 25% in the distribution of the FIT results. And here you see the results in the participants with advanced neoplasia. So this is a subgroup with advanced neoplasia in the males and females. And we see that in the males with advanced neoplasia, there's a skewed distribution to the right in terms of hemoglobin in phases detected, so a higher third quartile than in the females. If I then look at the group without advanced neoplasia detected at colonoscopy, and also look at the third quartile, so the point that separates the lower 75% from the upper 25%, I see a similar pattern. So males, as we know from other studies, have more hemoglobin even if they don't have advanced neoplasia detected at colonoscopy. And if we look at the results according to age, we see a pattern that more of the elderly without advanced neoplasia have some hemoglobin in their faces. Now that difference in distribution of FIT, of hemoglobin in feces, has consequences for sensitivity and specificity. So if we look at sensitivity and specificity by sex, we see that there's a difference in males and females. So sensitivity is higher in males and specificity is lower. If we look at the distribution of sensitivity and specificity by age, we see a similar pattern. So a slight decrease in specificity, these are the blue bars, and an increase in sensitivity, which are the green bars. As before, I have not included the statistical uncertainty in these bars, but the results are consistent with what we know from other studies. So differences in sensitivity and specificity. How does that translate into positive predictive value, as was mentioned by Professor Zappa? The positive predictive value is the proportion of people, participants, with a positive FIT results in whom advanced neoplasia are detected by colonoscopy. Well, there's also a difference in males and females. The positive predictive value is higher in males than in females. And if we look at the positive predictive value classified by age, we also see the same trend as we saw before. So a higher positive predictive value in the elderly compared to the younger participants. And the number needed to scope at this threshold ranges from 3.5 in the around 50 to 1.75 in the people close to 75. That means 2 out of 7 to 4 out of 7. So a substantial difference, a doubling in the number of people detected. So ultimately, what does that mean for the yield of FIT screening? So how many participants have advanced neoplasia detected through screening? Again, we see a similar pattern between females and males, more advanced neoplasia detected in male participants than in females. And with age, again, we see the same pattern. There's more advanced neoplasia detected in the elderly compared to younger people. The number needed to test in the young is around 1 in 60. The number needed to test is 10 in the elderly, so a 6-fold difference. So there are substantial differences in fit performance and in the yield of screening by age and sex, in the risk of having advanced neoplasia, and in the distribution of fit results, but also in fit positivity and other performance characteristics of fit, and ultimately also in the total number of life years gained by fit-based screening. So what to do about it? It means that there are differences in fairness of screening and also differences in the efficiency of screening based on age and sex. Now, we cannot do much about the risk of having advanced neoplasia unless we focus on prevention. We cannot do much about the distribution of fit results between males and females and young and elderly, but we can change fit performance. We can change fit performance if we change a single positivity threshold, as we are now using most of the time, to a different positivity threshold, for example, a lower threshold in females than in males. Some programs actually do that. So this study from Sweden announced that a lower threshold is being used for females, 40, than in males, 80, to yield a similar number of positives in females and males. But if we focus, for example, in positive predictive value, we should use a different threshold. We actually should use a higher threshold in females than in males. So fewer false positives, more true positives, in order to restore the positive predictive value. And one of the people in our study group, Tim Kortlever, has recently completed an analysis in which he showed that the fit cutoff concentration to yield a similar positive predictive value should decrease with age and should be different in females and males. And here you see the cutoffs that are needed to generate similar positive predictive values across people that differ in age and sex. So lower in the elderly and lower in males. So the question is, we can adjust it upwards or adjust it downwards, and it depends on our priority. Which performance differences do we want to reduce? Number of positives, sensitivity, specificity of other characteristics. And at this point, I'd like to hear from you, from the audience. So which differences should be reduced by changing the cutoffs? And you see the options on the Zoom poll that is currently on the screen. So please, I would like to have your votes. This is not Eurovision contest, which is happening a few kilometers from here, but nevertheless, I'm very much interested in your response. And please take your time to vote. And I see the majority of people, there's quite a range of options. So I'd like to have a screenshot of these results because it shows that the community is not unanimous in its predictions, in its preferences, but there's a slight majority, 29% for fit positive predictive value, which is also my personal preference, because aiming for equity in the positive predictive value means that we have a comparable benefit burden balance for those undergoing colonoscopy, and also aims at comparable number needed to scope, so an efficient use of resources, and it can be objectified. The previous speakers have already alluded to some of the challenges. So in doing so, we should also account for these features And we know that in adding complexity also makes the whole program more error-prone. And in the end, we have to find out whether aiming for equity and positive predictive value or some of the other features actually restores equity. Restoring equity makes it more acceptable to people. So my key message is that most programs now use a single positivity threshold, but given the differences, that doesn't mean that we have equity, fairness, and similar efficiency. So using different fit positivity thresholds could restore equity and efficiency. And with that, I'd like to thank you for your attention, and I'm happy to hand over to the chairs of this session. Thank you very much.
Okay, thank you very much for the nice presentation. So we only have 5 minutes for discussion, so maybe we can only take one question. So I identify one very interesting question from the audience. So the question is, has anyone examined the risk of colorectal cancer for patients with a single fit hemoglobin concentration value of 0 compared to unscreened individual? And the examining cumulative incidence of this group might provide insight into how long a value of 0 might be protective and whether the interscreening interval could be prolonged for this specific group of people. So may I invite Iris to answer this question?
Yes, thank you very much. And actually, thank you very much for this very interesting question, because we have been looking at this. We are currently in the preparation for hopefully conducting a randomized controlled trial within the Dutch colorectal cancer screening program, where we're going to offer half of the individuals the regular screening, and the other half of the individuals will be offered a screening interval based on their prior hemoglobin concentration. And we're currently trying to look up all the numbers to support that we want to do this for requesting ministerial permission for such a trial. And one of the things that we looked at is at the interval cancer rate plus the screen detection rate in the subsequent screening round, individuals without any fecal hemoglobin concentration in their first screening. And we see that actually, if you add the screen detected cancers and the interval cancers all together for this group, that the risk in this group after 2 years plus screen detection cancers is still considerably lower than the risk in individuals that score between 0 and 15 micrograms per gram feces, which is currently sort of the middle risk group. And what we see there is that this group already after 1 year has a higher risk than people with 0 blood in their stool after, you could say, 3 years, so 2 years plus the screen detected cancers. So this is definitely something that we look into. Unfortunately, currently we're all re-inviting those individuals after 2 years. So we don't know what happens after 3 years, although we could, with again, a silver lining of the COVID crisis, we have somewhat longer intervals now, and we are hoping to look at that later on, but we don't have the results for that, unfortunately.
Okay, so because we are running out of time, so we still welcome all the audience to post their question in the Q&A box, and our speaker will be happy to answer. Okay, so Luke, may I invite you to close this session?
Okay. Thank you so much for all the participants. I think that discussions should be standing a long time, and we hope that COVID-19 will let us alone in the near future. And let's work hard to get the numbers of the pre-pandemic colorectal cancer screening. Thank you all for your participation, and let's meet again in about 5 or so minutes. Thank you so much, and bye.
We will be taking a 5-minute break now.
No problem.
Welcome back to session 2, which is chaired by Evelien Dekker and Asma Shaukat.
Hello, everyone. My name is Asma Shaukat. I'm professor of medicine and chief of GI at the Minneapolis VA and University of Minnesota. My co-chair needs no introduction. Evelien Dekker is a professor at the Amsterdam Medical University and also a gastroenterologist and a researcher in colorectal cancer. We have a very interesting session for you all about quality of colonoscopy. So we'll get started and keep introductions brief. So I'd like to introduce the first speaker. Our first speaker today is Pratik Sharma. Dr. Sharma is a professor of medicine at Kansas University School of Medicine and is a well-known researcher in endoscopy, particularly Barrett's and GERD, but also on artificial intelligence. He is a board governing member of the ASGE and also the chair of their task force on artificial intelligence. He'll be talking to us about artificial intelligence for quality assurance of colonoscopy. Dr. Sharma.
Hi, thank you. Thank you, Evelyn and Asma, and it's my pleasure to be here. So in the next several minutes, I'll lay the groundwork of how AI can be impacting quality measures in colonoscopy. And I'd just like to start off with this wonderful slide that Michael Kaminsky used at the UEG week a couple of years ago, and sort of highlights how quality in colonoscopy is related to these different domains, as well as the key performance measures, right from pre-procedure, in which you start assessing the adequacy of the bowel preparation, which is typically used using the Boston Bowel Prep score, the completeness of the procedure, which is an intra-procedure way of looking at quality, for example, cecal intubation rates, identification of pathology and of polyps during colonoscopy, or the adenoma detection rate, or the ADR. This is something which is of interest to therapeutic endoscopists to make sure that you have done adequate resection and a complete resection of the polyp, so an appropriate polypectomy technique. And then post-procedure, we are interested in follow-up in terms of complications as well as patient experience. So let's just take each one of these, starting right from the pre-procedure part, at least up to ADR, where we have good key performance measures or metrics which are listed by the various GI societies globally, and to see how artificial intelligence could be playing a role in each one of them. So let's start off with, for example, assessment of the bowel prep by artificial intelligence. And here's a study from gastrointestinal endoscopy a few months ago, in which there was a real-time assessment of the Boston bowel prep using a machine learning algorithm. You can see as this withdrawal is being conducted and the bowel prep is being calculated, here's the cumulative score, 0, 1, 2, 3, according to the Boston bowel prep score. And this is highlighted in these images here of what 0, 1, 2, and 3 refer to endoscopically when we are measuring that. Now, right now, all of us look at the different segments and we grade it at the time of endoscopy. Now, wouldn't it be helpful if real time this can be calculated for us, so we can pay attention to the patient as well as to the procedure rather than grading this? This was done in a training set, which is shown here. And the algorithm used here by proprietary was through EndoAngel. And if you look at the overall accuracy of assessment of the Boston bowel prep, which was compared between the machine versus novice endoscopist, senior endoscopist, expert endoscopist, you can see that the machine outperformed all endoscopists when it came to looking at the accuracy of the Boston bowel prep score. And it was through not just driven by either a perfect score or a worse score, but all across the Boston bowel prep score from 0 to 3, you can see what the accuracy was. The second is cecal intubation rate, or looking at landmarks. And, this is one way of doing it. Is on the left, you can see that in the cartoon form, once you reach the cecum, here's the appendiceal orifice, the ileocecal valve. This is automatically recognized by the computer as you're doing the procedure, so it can get to the time to the cecum, as well as what your cecal intubation was, yes and no, and therefore whether your cecal intubation rate over 100 procedures is being maintained or not can be looked at with the help of some of these algorithms which have been designed. The other thing what it does is that it will calculate not just your insertion time, but also start looking at your withdrawal time, which is shown on this clock here. The loss of view refers to not just the withdrawal time, but also the adequacy of inspection of the colonic mucosa as a gradual withdrawal is being performed. So if you are performing a withdrawal which is too fast, the speedometer goes to the red side, which tells you that you probably need to slow down. If you are in the green range or somewhere in between, that's probably where you want to be, which would equate to a withdrawal time of at least about 6 to 8 minutes as you're doing that. Also, if the view is lost, it will alert you that you're not doing a good job in looking at the colonic mucosa, which, as we all know, impacts the adenoma detection rate. So all these tools, I think, will be there in the future when we start measuring quality in endoscopy real time, and also more importantly, as teaching tools for our trainees and the junior endoscopists. The next major quality metric is adenoma detection rate, and this is shown here in real time by using a bounding box which appears around a lesion which is seen during the procedure, alerting the endoscopist that a polyp has been visualized. Now, this is the area where a lot of randomized controlled trials have been conducted to look at the ADR, and has led to the approval of several devices all over the world. And in the US, which sort of struggled behind in this, about 3 weeks ago, the first AI device for colonoscopy was approved in the US as well by the FDA. This is one of the earlier randomized controlled trials. This is from China, looking at just over 1,000 patients who are randomized to either an HD colonoscopy without AI or an HD colonoscopy with a CAD-E device or an AI device. And when the input was seeing a polyp, the probability map is created internally, and then the output, which again, and traditionally, is in the form of a bounding box with or without some visual or audio clues in terms of a ping or a ding, which appears, and you can set that as how you want it. Here, if you look at the primary goal of the study, which was to look at the adenoma detection rate, you can see that the adenoma detection rate, or the APC, or adenomas per colonoscopy, or adenomas per patient, were significantly higher in the CAD-E group or the AI group as compared to the standard group without the AI device which was used. Now, that was a study from Asia, in the Asian population, which traditionally has a lower incidence of colorectal polyps, specifically adenomas. This is the European study published last year in Gastroenterology, close to 700 patients, both in a screening and surveillance population. Again, a very similar study design of looking at an HD colonoscopy with or without AI in this situation. And this is, again, a similar output which the machine gives you. Again, a statistically significant improvement in both the adenoma detection rate as well as the APC, or the adenomas per patient in the study, which were detected. And the significance was maintained through all different sizes of the polyp in this study. So what this led to is a systematic review and meta-analysis published in Endoscopy a couple of months ago of 5 randomized controlled trials with 4,300 patients or so. And you can see that there is a significant improvement in the adenoma detection rate all across the studies, with a significant difference in this meta-analysis showing an improvement in the ADR of the range of about 10% with this devices when this was used. However, there may be some downstream sort of effects of these which are not good, such as the false positive rates. And will that prolong the colonoscopy procedure or create more distraction to the endoscopist if the boxes are coming up too frequently? And this is what was looked at in this study of looking at, two expert endoscopists who looked at all these videos and figured that there were close to 1,000 false positives which were identified. They decided to group this as, are the false positives coming from the bowel wall or from the bowel content? And in the majority of the cases, it's usually the bowel wall. And what this means is either it is a prominent fold, it's a suction mark, which is actually leading to the machine to recognize that as a lesion rather than pure bowel contents such as stool or pills, which we could have been concerned about. They further subclassified as how much time was required to look at these lesions. And you can see that for the vast majority, close to 80%, 3 seconds or less are required to look at false positive, and for the endoscopist to say, it's nothing to worry about, let's just move on. So it does create these distractions, but at least in this study, it appeared to be that these were minor distractions. And again, remember that these are 1.0 machines right now. In versions 2.0, 3.0, I'm sure that a number of these issues will probably be dealt with and will be much better. The second is that once the machine has identified that there is a lesion, it would be important to recognize if this is an adenoma, is it a hyperplastic polyp, is it a sessile serrated lesion, what is it that you're dealing with? And this is showing on the left that it was a tubular adenoma after the machine's analyzing it. And on the right, it is analyzing again this small diminutive polyp seen in the sigmoid colon and is recognizing it as a non-adenomatous lesion, which is there. And this was looked at further in the study initially from Michael Byrne and this group, in which they looked at NBI videos of these different polyps that they had collected using the NICE classification. And here, what the machine is doing is giving you the confidence level of the machine of whether this is a type 1 or a type 2 polyp according to the NICE classification. And the PIVI criteria have been met by these different algorithms which have looked at the real-time characterization of polyps. And so it's possible that rather than using NLP or manual chart extraction for these calculating the ADR, perhaps we can rely on these machines to not just recognize the polyps, but also tell us how good they were in looking at this. And here's just telling you the sensitivity, specificity, and you can see the negative predictive value of 97% in these machines to look at tubular adenomas and identify those correctly. So ADRs can also perhaps in the future be characterized real time, and the calculation can be done rather than a retrospective way of spending time, assigning a nurse, etc., to look at what the ADR is. So here's what I'll end up with is I think that in terms of the adequacy of bowel preparation, there's good data that AI can help you. Similarly, for cecal intubation rates, adenoma detection rates, as the therapy is also being looked at, I think AI is being evaluated to look at the adequacy of polypectomy, and it can thus help us in improving all these quality metrics during colonoscopy. Thank you all. And again, thank you to the WOCRC committee for inviting me to this wonderful meeting. Thank you.
Thank you, Pratik, for that excellent presentation. All participants are encouraged to write their question answers in the question answers box, and we'll try to get to them at the end of the session or just answer them in the chat box. And it is now my pleasure to introduce our next speaker, Dr. Gloria Coronado. She's an epidemiologist and a distinguished investigator in health disparities research at Kaiser Permanente Center in California. And Dr. Coronado's research has focused on developing innovative and cost-effective interventions to improve participation rates in colon cancer screening programs. She'll be talking to us today about transforming colorectal cancer research findings into policy action. Dr. Coronado.
Wonderful. Thank you for that introduction. I am going to be talking about policy related to colorectal cancer screening today. And I just want to mention that I am filling in for my colleague, Dr. Bev Green from Kaiser Permanente, Washington. So in terms of policy as it relates to colorectal cancer screening in the United States, I want to talk a little bit about, the impacts of the Affordable Care Act. So we know that before the Affordable Care Act, on average, an individual would pay about $275 for a screening colonoscopy if they were covered on traditional Medicare. And so after the Affordable Care Act, that cost was covered in full by Medicare. And so that resulted in fewer out-of-pocket costs for people who were enrolled in the public insurance program of Medicare for people over 65. And what data showed is that this resulted in an 8% increase in early stage detection of colorectal cancer. And so I think we saw pretty quickly that the results of policy were pretty substantial, especially national policy. One of the other components of the Affordable Care Act was Medicaid expansion. And these are data from the state of Oregon specifically, where before Medicaid expansion, there were fewer than 700,000 people enrolled in Medicaid. And so just by way of background, Oregon is a state of about 4 million people, and Medicaid now covers about 25% of individuals in our state, which I think is pretty consistent nationally. So it's a public insurance program that generally covers people younger than 65, but it's really intended to provide coverage, healthcare coverage for people that meet certain income thresholds, typically about 200 to 250% of the federal poverty level or below. So what we see here is that overall Medicaid expansion significantly increased Medicaid enrollment in the state of Oregon by about 47%. But if you look at it by different age groups, what you see is that the highest proportionate change actually occurred in the age group that was 51 to 64. And we all know that this is a group that is eligible for colorectal cancer screening. And so Medicaid brought into insurance coverage individuals who were eligible for colorectal cancer screening and may have been without coverage for a long, long time. And so it's a particularly underserved population. And we see, that in recent years, so I know there's a lot of talk about COVID in the prior session, what we see is that in the past year, there's been another increase in Medicaid enrollment just due to job losses that occurred because of COVID. There were a couple of policy-related issues, that is that the federal government paused the disenrollment of most individuals because of COVID, and it allowed for self-attestation of eligibility verification. And then there was also an increase in federal spending for Medicaid programs during this time as well. And so in our state of Oregon, that resulted in over 9% a percentage point increase in Medicaid enrollment in the past year. So I want to talk about some other policies that I think have been really important in the state of Oregon. So one is that in 2013, the state provided incentives for the coordinated care organizations. So for Medicaid health plans that are operating in Oregon, incentives were provided for meeting benchmarks or improvement targets for colorectal cancer screening. And then in 2013, Oregon passed legislation to make a screening colonoscopy remain a screening procedure, even when polyps are removed. And I think for those of you in the US, we know that this has been a significant loophole that really creates issues for people who go in thinking that they're going to get a screening colonoscopy with no out-of-pocket cost and end up getting a surprise bill because polyps were removed. And then in 2014, Oregon passed legislation that required insurance companies to cover the cost with no out-of-pocket expenses for the follow-up colonoscopy for patients who tested abnormal unfit. This is a map of the state of Oregon, and this shows kind of the different geographic locations of the Medicaid health plans, which are called coordinated care organizations in our state. And again, this health plan covers over 1 million individuals in our state. These are the benchmarks and the targets that were set by the state for Medicaid health plans. So again, the policy was passed in 2013, it took effect in 2014, and the initial screening rate that was required to receive incentives was 47%. That percentage was maintained in 2015 and 2016. In 2017, it was bumped up to 51%. In 2018, it bumped up even further to 54%. And so we see that there were some really progressive stances made to kind of continue to increase and bump up that target as health plans were meeting it year over year. So if we look at the effects of this policy on screening rates, we see that, for example, by comparing the CCO or the rate among Medicaid health plans to, behavioral risk factor surveillance system data for the state of Oregon, we do see that the dark bar, which represents Medicaid rates in our state, that there was a gradual increase over time. And you can also note that those gradual increases really hovered around the target that was set by the state. If you compare that to behavioral risk factor data, which is a lighter blue bar, it was pretty stagnant. I mean, you see some kind of increases, but not the consistent trend that you see for Medicaid health plans. And when we compare data from community health centers, so this is called UDS data, and if we compare the rates for the US overall, which is represented in the first kind of light purple bar, if you compare that to Washington State, to California, and to Oregon, which is in teal, you see that the Oregon rates are increasing over time. And so these community health centers serve a predominance of the Medicaid enrollees. So most of the community health centers in our state, the proportion of the population served that's enrolled in Medicaid is typically 40% or higher. And so this gives you kind of a nice reflection of how those rates are increasing within these community clinic systems. And what you see in Oregon is there's, again, that increasing trend from 2016 to 2019. And you can compare that to Washington, California, and the US as a whole, where you see some increases, but you certainly don't see the dramatic trend that you see for Oregon. The other way that we looked at the potential impact of this policy was to look specifically at behavioral risk factor surveillance data. So behavioral risk factor surveillance is a telephone survey that's conducted every couple of years. And it asks respondents about their insurance coverage. And so within that data, we can compare individuals that are enrolled in Medicaid and those that are not enrolled in Medicaid. And again, I think you see a pretty consistent trend where in 2014, there was a significant difference in screening rates between Medicaid enrolled and non-Medicaid enrolled individuals. And that disparity really was eliminated by 2017. So you see the blue bar that's increasing up to the 73%. There was another drop that happened in 2018, but I think this data is pretty compelling to suggest that the policies that were put in place seem to make a pretty big difference in terms of people's ability to get screened. So I wanted to say over the past 5 years, Oregon has really introduced some legislation and policy that supported colorectal cancer screening efforts. And I think that we can see some evidence that these policies have had an effect. And I think in addition to the effect that we see in these data, we've heard anecdotally that it's really helped the health plans improve their data quality and tracking. And it's really supported stool-based testing as first-line screening. And so by taking away kind of the out-of-pocket cost for the follow-up colonoscopy and so forth, that we've really paved the way to allow providers to feel comfortable recommending colorectal fecal testing as first-line screening. So where has this led? So Dr. Bev Green and I collaborated on a program from 2016 to 2018, where we worked with a couple of different Medicaid health plans, one that was based in Oregon and one that's headquartered in California, but served enrollees in Washington State, among other states. And we really supported these health plans in kind of mailing out fecal tests to eligible enrollees. And so they really implemented different programs, but the research team really helped them with the evaluation. And what we implemented was a 2-year program. So Oregon was very enthusiastic and really interested in engaging the clinics in this work. The health plan in headquartered in California really kind of took on a more centralized approach where they didn't collaborate as much with clinics. And one of the big differences is that by year 2, Oregon was really growing its program and including more and more clinics, whereas the Washington-based program was actually shrinking. So there were no incentives that were in place for enrollees in Washington State. And so they decided to scale back their program in the second year of implementation to only focus on those patients who were dually enrolled in Medicaid and Medicare. And so this is a significant difference between the two programs. And as we thought about kind of disseminating our research findings, the Washington team really shifted its goal from really just disseminating that information to really thinking about how they could advocate for a national Medicaid colorectal cancer screening metric that would require that these Medicaid health plans report their rates each year. Because what they realized was that not having that policy in place really affected the prioritization. And so Bev Green and Stoney Anderson in California and the whole C4 Coalition and the National Colorectal Cancer Roundtable got together and decided to petition for the inclusion of colorectal cancer screening as part of the core measure set for Medicaid. And so it was evaluated based on its actionability, its alignment with the larger program, its appropriateness at the state level, the feasibility, as well as the strategic priority. And recently, at the beginning of this month, it was actually approved. It has to go through a second step of being approved by CMS, but nobody foresees that there will be any problem. So this is a big win, and I want to just emphasize that there are a lot of people that helped make this happen. And what this means is that Medicaid health plans in all the states in the US will now be required to report the rates of colorectal cancer screening, which really paves the way for other states to include that as an incentivized metric for their states. So just by way of conclusion, it was really a combination of research and advocacy that led to the inclusion of colorectal cancer screening as a core reportable measure for Medicaid health plans. And I just want to acknowledge the team members for benefit. I think it's important to also acknowledge the C4 Coalition and the National Colorectal Cancer Roundtable. And also want to note, we have a website for our research, mailedfit.org. Thank you very much.
Thank you very much, Gloria, for your wonderful talk. I would like to immediately introduce the last speaker. I don't see myself, but that's because I can't start my video, but that's fine. My name is Evelien Dekker. I'm the chair of this session. Yes, here I am. I would like to introduce Catherine Dubé. She is an associate professor of the Department of Medicine and the Division of Gastroenterology in the University of Ottawa. And besides that, she's the clinical lead for Colon Cancer Check. And I look forward to her talk on improving screening quality in Ontario, Canada. Please go ahead.
Thank you very much. I'm just opening this up. And here we are. So thanks to the organizers for allowing me to present. And the objective of this presentation is to describe to you the approach to quality management in screening and colonoscopy in Ontario. I have no interest to disclose. And if we consider quality in health, one can consider these three domains as proposed by Donabedian years ago, where we have the structure, meaning the settings in which care is delivered, which would imply the equipment, human resources, and funding. We have processes, which is actually what happens during care. And this is influenced by patient behavior, by providers' interventions, and things such as clinical policies. And obviously the outcomes, which is the effect of care on the health status of the patient, and in our setting, things like complications, obviously, and patient satisfaction. And in trying to understand the approach to quality in our program, it helps to know exactly this sort of structure and processes. So in Ontario, colorectal cancer screening is organized by the Colon Cancer Check program, which is really in charge of sending invitations, funding and quality assuring the lab and setting standards. And it also works with 13 regional cancer programs, which are networks of hospital administrators, clinicians who are tasked with implementing standards and programs to support cancer care. Each one of these regional cancer programs also has a clinical screening and endoscopy lead, so a so-called regional champion. And in parallel with that, and initially completely separate from this, colonoscopy services. So in order to obtain a colonoscopy in Ontario, primary care will refer to an endoscopist, typically a gastroenterologist or a surgeon. And this endoscopist may perform the procedure either in a hospital or in an out-of-hospital premise. The oversight for hospitals is performed by the Ministry of Health, and they also participate in voluntary accreditation programs, while out-of-hospital premises are under the College of Physicians and Surgeons of Ontario. So the challenge in all this is to create a shared vision of quality through this spectrum of administrative and clinical networks, and to engage endoscopists at the same time. Our quality management program has 5 key elements, which are somewhat interdependent. First, a strong scientific basis that underpins the other activities, a governance structure that creates accountabilities at the regional, hospital, and individual level, funding of hospital-based endoscopic procedures, quality reporting using measurable indicators, and quality improvement activities. And so in terms of the evidence and data collection elements, emphasis on evidence-based care and data collection was established from the start of the program. Even before the launch of the CCC program, Linda and colleagues published a series of landmark studies of outcomes of colonoscopy in Ontario and Canada, which really brought to light the importance of monitoring and improving colonoscopy quality across the country. And then the launch of the Colon Cancer Check program in 2008, which from the start embedded a structure that has a dual scientific and clinical leadership that ensures rigorous methodology for data collection, analysis, and reporting. And then the CCC program could fund some screening-related colonoscopies in hospitals. And in return, hospitals were tasked with providing data on all of their colonoscopies. And then in 2014, we published colonoscopy quality assurance guidelines, which were also evidence-based. And so eventually the program over time developed methodology to validate and refine various data sources and to create integrated screening related and colonoscopy reports, related reports, such as the GI integrated endoscopy and screening report, which is updated monthly and gives regions a sense of their volumes of FIT testing, numbers of FIT positive individuals, wait time from abnormal FIT to colonoscopy, colonoscopy volumes by indication, and as of last year, a backlog management tool. Physicians and facilities are also provided with an annual quality report, which I'll describe to you in coming slides. Primary care physicians also receive screening activity reports, and of course, reports are created for various program performance reports. And so the funding element has evolved over time. The Ministry of Health established the health system funding reform, which led in 2015 to the creation of the quality-based funding for GI endoscopy in large hospitals. And then through this new funding model, endoscopy funding was carved out of the global hospital budgets and has since been administered by Cancer Care Ontario, Ontario Health, and it creates direct accountability between hospitals, those regional cancer programs, and the screening and quality management programs. And so this has been really a good, important leverage. It helps promote the standardization of care. It improves accountability and provides further impetus to collect data from hospitals. And so in combining all this, we have a colonoscopy quality management program that includes standards and guidelines, quality reporting, clinical leadership at each of the provincial, regional, and facility level, and quality improvement resources. And I'll describe those to you in these next slides. This slide here is the example of our facility level quality reporting. So on a yearly basis, all facilities, both hospitals and out of hospital premises, receive this report, providing them data on their resources, on their demographics, and also on their performance indicators. The physician level quality report was first implemented through an Ontario-based randomized controlled trial that included the distribution of this report to all endoscopists, plus or minus a quality improvement intervention of facilitated feedback. So now, since then, every year, the physicians receive this report informing them on their colonoscopy volumes, on their polyp detection rate, on their quality indicators. And over time, this report has been evolving and refined. For example, at first, we were only able to inform physicians of their polyp detection rate, but then develop natural language processing methodology to extract the ADR from pathology reports. We also have been now distributing these reports through an electronic confidential platform, which allows the dissemination of record level data so that individual endoscopists can go back and review their PCCRC cases, for example. The design of this report was also informed by research. And for example, these cues of the thumbs up or down are meant to engage the endoscopist in quality improvement intervention without using judgmental or punitive approach. The next very important component of this program is the facilitated feedback. Each year, about a subgroup of about 6% of endoscopists that we identify as poor performers are then submitted to this intervention. They are coached by our regional or provincial leads who have been trained in the coaching. And this approach is evidence-based and also theory-based, and this was developed by Dr. Joan Sargent. It has 4 steps, if you will. First of rapport and trust building, and then exploring reactions, so taking that emotional reaction to the report, to then discuss with lucidity what the report is actually saying, exploring the content, and then coaching for change, and really trying to develop an achievable learning plan. And the evaluation of this program has been several fold. So first of all, I mentioned earlier that we did an RCT of over 900 endoscopists looking at the impact of these audit and feedback, and found that there was a significant improvement primarily in the polyp detection rate for poor performers. Those who were the other performers, we did not see a difference with the audit and feedback. The qualitatively, these physician reports are found to be useful by the providers. They've found that they provide helpful information and that they can help identify areas for improvement. And as far as the regional leads are concerned, who are our coaches, they found they were able to implement a facilitated feedback process without difficulty, and that the endoscopists were receptive. So is quality truly improving? What about real world data? This slide shows you our performance metrics over time as for the years that we were able to measure them. And we can see for these process measures that there is some encouraging improvements, for example, with polyp detection rates and preparation, quality of the bowel prep. Similarly, and possibly for these outcome measures, there seems to be downward trends with post-polypectomy bleed. So while these results are encouraging, the question is, could we be doing any better? In particular, is our program truly able to identify those in most need of performance enhancement? And are we properly closing the loop on colonoscopy quality? These are ongoing questions and challenges. Currently for our program, we're currently undergoing a systematic review of quality indicators for colonoscopy. And we're also looking this time at standards for competency, both for endoscopists and endoscopy assistants, looking at techniques and tools of endoscopy. And so this systematic review will lead to updated guidelines and likely some updated indicators and change to our reporting over time. We do see that there is a need to better develop this closing of the loop on quality and performance. We're very fortunate in Canada to have access to excellent resources through the Canadian Association of Gastroenterology, for example, with the skill enhancements in endoscopy program and the CGRS platform. And although a good proportion of facilities are using, for example, the GRS and most endoscopists are aware of the C program, this could be used more over time. As well, looking at our governance, we need to engage our facility leads further so that we have more feet on the ground and more involvement at the level of the facility, which I think in time will help further strengthen the endoscopist engagement, because this keeping the endoscopists engaged remains a challenge as we continue to have some discordance between the actual colonoscopy services, the way colonoscopy is provided in Ontario, and the way screening is offered and organized. So in summary, I hope I've been able to adequately describe to you our screening and colonoscopy quality management program. While we continue to face some challenges, looking back at the program and how it evolved over time, I think it justifies the way it was started, using what was achievable and possible at the time, and improving with opportunities and with good data collection that make us see areas for improvement, and then go on and in the same way as quality improvement is performed overall. I think for programs in general, it's very important not to expect to achieve perfection from the start, because otherwise you'll never get started, and it's really a case of climbing up that hill one step at a time, I think. And in closing, I really need to acknowledge the tremendous team of talented and dedicated people working with me at Ontario Health Cancer Care Ontario, from Jill Tinmouth, the scientific lead for the colon cancer check, Linda Rabinek for her vision, her rigor and leadership, and all of these others. Thank you very much.
Thank you so much. Excellent talk. Please put your questions in the QA session. I'll start with the first two questions to you, Pratik. First question, can AI detect SSL histology, and how good is it? And second question, how do you see the implementation of AI, especially with GI Genius being rolled out? What are the barriers?
Okay, thanks, Asma. So for the first question, I think is in clinical trials about the use of, so we're currently performing one of those clinical trials to look at the role of characterization of SSLs. As you can imagine, it's a little bit challenging right now because of the pit patterns being quite similar to even diminutive hyperplastic polyps. So it is in the works. That's what I would say for SSLs. None of those are commercially available. The second point about implementation, at our center, I mean, right now, we're doing it as part of clinical trials and 3 different devices. The setup is quite easy, I would say. I mean, it's most of them are plug and play devices, so you can, have your IT folks at your institution help with that. For the majority of these devices, I would say that it took us less than half a day to set those up and have them go into our endoscopy screens. The challenge right now would be, the costs associated with it. As you know, I mean, there's really no reimbursement for that. So, I mean, those are all other issues related to the use of AI in colonoscopy. But as far as setting it up, it's pretty seamless.
Thank you so much, Pratik. So I have also a question for Catherine. So one of the questions from the audience is on the how you assess adverse events. Do you have any specific method to try to make that really reliable?
Mm-hmm. So, I mean, I went pretty quickly on that slide, but we use a combination of databases to identify the colonoscopy and then look at the hospital admission databases using a validated algorithm to identify post-polypectomy bleeding and perforations. The post-colonoscopy colorectal cancers is obviously a separate methodology, but that also links up with the Ontario Cancer Registry. And this is our last kid on the block was the PCCRC reporting. So it's really based on a large database. With the PCCRC, as I mentioned, we're able to inform clinicians of the case in particular. And we learn in the process because we hear back from them telling us, well, in fact, this was not quite the scenario and so on. So it's not perfect, but it entices that review of the case, which is the quality improvement intervention.
Yeah, and so how about the complications after colonoscopy? Don't you have a problem with patients showing up in another hospital than the one they were scoped in at the first place, or do you have a coverage for all of that hospitals, and are they linked to?
Yeah, we have the database that includes all hospitals.
Also, when people show up coming back.
Yeah, and it's not hospital specific. It's.
Oh, that's impressive. Yeah. So another question, which is on the, a colleague of yours, Kevin Selby, who says he was amazed by your program, but he's curious what you do with potential poor performers over the years. So do you have those? And are they still open for discussion, or is there, he doesn't ask, but it's my question, is there a way of, in the end, trying to stop them from doing those relatively high risk colonoscopies?
I mean, it's almost anecdotal at this stage because I think there are some repeat, offenders that we keep seeing, and the interaction with the regional lead has been ongoing. I think several of these cases are people who were just about to retire and who in fact retired as, a very low volume, more complications. So some of these sort of solve themselves. And
isn't it the other way around as well, that very young endoscopists just don't have yet the experience to be good? And don't you see at both ends?
Both, but the receptivity to feedback and improvement is quite different. And. Mm-hmm.
Okay, great. Thank you so much. So for Gloria, there's not much questions. Actually, a lot of appraisal on all the work you've done and the success you've had. So I think my sole question on that would be, what is your, if you would have to point out one factor for success, because indeed, I think it's impressive what you have accomplished. If you would have one factor for success for other maybe states in the US or nations, what would be your suggestion?
Wow, really good question. Boy, it's hard to pinpoint kind of one factor, because I do feel like there were a collection of different events that took place. And so, you know, in terms of making Medicaid an incentivized metric for the state's Medicaid health plans, that really came from me deciding to be part of that committee and advocating to include it as a metric back in 2013. And I remember some of the pushback was that, you know, Medicaid we don't have very many enrollees that are age eligible. Like, we're a program for women and children. And I remember saying, well, you know, let's just check. Let's just look at the data. And they came back and presented data and realized that there were about 20% of enrollees that were age eligible. And I think that what we do see is that there was a lot of enrollment in that age group. We also know that with the guidelines changing, that there's going to be even more that are Medicaid enrolled that are now going to become eligible. And so I think that it took really kind of saying, well, let's check and let's look at the data, and then convincing people with data that it made sense. I think also there had been other states that were including, you know, breast cancer screening or cervical cancer screening as a metric. And I think the case that was made there was that, hey, this is one that does cover adults. It covers both men and women. And so, and there's even greater kind of opportunity to save lives because the screening rates are so low, particularly in the Medicaid population. So I think it's really like having those arguments handy that really helped, and then doing the on the ground work to say, you know, wow, what we're seeing is that it's a big motivator for Medicaid health plans. And then I think in the early days too, we had a research study funded. And this is when our providers are like, we're not inclined to offer FIT testing because patients might face out-of-pocket costs for what now is a diagnostic colonoscopy. And so that's when we got together and met with Mitch Greenlick, who was on our legislature in the state, and he was on our advisory board. And my position at Kaiser is named after him. And so I knew that I had kind of an insider's, you know, connection. And so he was incredibly helpful at just making that happen in our state legislature. So we just got really lucky with being able to line things up.
Yeah, lucky, but also a big accomplishment and
persistent, I guess. And then
especially, I think the factor that you have data to show and to, I think that sounds to me as a very convincing way of getting this done.
And then had a network of people in California like Samir Gupta and Stoney Anderson and others, and then obviously my collaborator Bev Green in Washington, who really wanted to take it to the next level. So really feel grateful.
Thank you so much for sharing your experience and accomplishments with us. Same for the other speakers. Of course, also Catherine with her quality program, and Pratik with the insights on the AI, and that's the opportunities it's offering us for the future. I really enjoyed this session. We have a break now. We were planning on a 15 minutes break, but as we are still trying to catch up a little bit, it will be 10 minutes only. So you can quickly get your coffee, tea, wine, whatever time it is in your country, what you would need most at this moment. And I hope to see you back in 10 minutes. And thanks again for wonderful speakers. Thank you.
Thank you.
NS Prime. Retaining the features of the former model, NS+, the NS Prime has been upgraded with many new features to improve the accuracy, speed, and efficiency of fecal immunochemical testing. Let's take a look at the new features. To help make the management of tests easier, calibrators and controls are now equipped with barcodes, allowing you to automatically register the reagents, calibrators, and controls in one easy step. We have also improved the dispensing accuracy and durability of both the R1 and R2 dispensing arms by utilizing metal probes. In addition to 6 2-rack trays, we have added a 10-rack tray, allowing you to load up to 100 samples at once. The system's high-speed processing capability can perform 300 tests per hour, even when performing multiple tests on each sample. While we currently offer 2 reagents, the NS Prime is designed to accommodate up to 5, meaning that you can continue to use this model even as more reagents become available. And thanks to the built-in refrigeration, reagents can now be left on the reagent rack for up to 5 days, eliminating the hassle of putting them away each day. Our NS Prime has attained higher accuracy, higher speed, and higher efficiency. Alfresa Pharma Corporation, continuing to serve your various needs. Alfresa.
How you doing? How can we help you?
And you put your rolled up thing into this biohazard bag.
It's a drive-through mini clinic. You come around the corner and there's a nurse's station. You'll get a glucose, blood pressure screening, as well as a colon fit screening.
This pop-up, socially distanced event is the latest iteration of a pilot project funded by the National Cancer Institute in partnership with community organizations. Along with a collection of health screenings on site, participants also get a fit kit to take home.
A fit kit is a test that actually detects one chemical that's found in blood and therefore allows doctors to determine if there might be hidden blood that no one can see with the naked eye in the stools. And hidden blood in the stool is one of the earliest signs of a polyp or a colorectal cancer.
The church has created an opportunity for individuals to simply drive up, pick it up, take it home, and bring it back and drop it off. It removes a lot of the barriers for individuals.
At the first set of events, held in the fall of 2020, participants got flu shots along with fit kits. The project received international attention at the AACR virtual meeting, COVID-19 and Cancer, convened by the American Association for Cancer Research.
We are so grateful to the AACR for highlighting our study during its COVID and cancer conference, because I think it really allowed us to have a platform to be able to show that the declines that we've seen with COVID, cancer screening in particular, can be mitigated with a model that I think we've shown has some really early promise of being effective. And so all of us can benefit from conferences like that where we learn about potential best practices.
The results presented at the AACR conference showcase some impressive numbers. 192 participants received a fit kit, and over 90% of them self-identified as Black. 154 of those who received the kits completed and returned their test. 13 tested positive. 48-year-old Stacy Hill is one of the faces behind the number of positive results. She got a call from Armenta, Washington.
She told me not to worry, but I did. It was near the holidays, and I told her, like, I don't have insurance. I was like, she said, because, you know, the next step will be for me to get a colonoscopy. I said, I don't have insurance at the time. You know, I lost my job. I said, so I don't know what to do.
Washington spent lots of time on the phone and the computer, helping Hill and others with positive results navigate the health system to undergo a diagnostic colonoscopy. During Hill's procedure, doctors successfully removed 2 polyps that potentially could have turned into cancer.
Sometimes when they find something, if they find it in time, it saves your life. And that's the most important part of it.
Saving lives is exactly what organizers want to do with these fit kits and more pop-up events in the future.
We can do this. We can reduce disparities, and that gives me so much hope.
When you have a level of success with something like this that's out the box, you just begin to think that all things are possible.
Welcome back to session 3, which is chaired by Rolf Hultkrantz and Jason Dominitz.
Well, welcome to session 3, which is about colonoscopy. I'm Rolf Hultkrantz and I'm a professor of gastroenterology at the Karolinska Institute at Stockholm, Sweden. My co-moderator is Jason Dominitz, who is the National Director of GI for the US Veterans with Health Administration and a professor at the University of Washington in Seattle. As before, we will have all the questions after the talk, so please use the Q&A box. The first talk is entitled Systematic Review on Talking Surveillance of High-Risk Lesions by Sandra Maxia. Sandra is a PhD student and a fourth-year resident of gastroenterology at Hospital General Universitario at Alicante, Spain. So please, Sandra.
Hello, thank you for the introduction and invitation to present our results. So I'm going to present this study that is a systematic review and meta-analysis on risk factors for metachronous colorectal cancer or advanced polyps after endoscopic resection of premalignant lesions. So as you all know, the removal of adenomas has shown to reduce colorectal cancer incidence and mortality. And also, as you can see in the figure, there's a subpopulation of patients with adenomas with high-risk features where the risk is higher, supporting surveillance, especially in this population. Different guidelines have established different recommendations on post-polypectomy surveillance, depending on baseline adenoma features. And as you can see in the table, in general terms, the recommended interval of surveillance for patients with adenomas with high-risk features is of 3 years. However, the recently published ESGE guidelines do not recommend surveillance for patients with up to 4 adenomas or adenomas with villous features. And even more, the European Commission and the US Multi-Society Task Force guidelines establish an even higher risk group where a recommended interval of surveillance of only 1 year. All this has led to post-polypectomy surveillance becoming one of the main indications for colonoscopy, accounting for almost 25% of colonoscopies in Western countries for male patients older than 50 years, with the consequent burden in endoscopy units. This recently published systematic review and meta-analysis shows how patients with low-risk adenoma or normal colonoscopy have a low risk for metachronous colorectal cancer incidence, with no difference in mortality between these two populations, and also show how patients with high-risk adenoma in baseline colonoscopy have both a higher risk of metachronous colorectal cancer incidence and mortality. Our hypothesis, however, was different and is based on what has been suggested in previous studies, that is that some of the current high-risk characteristics, namely multiplicity, size, high-grade dysplasia, or villous structure, may relate to a higher risk of metachronous colorectal cancer or advanced lesions than the others, and therefore, some patients with high-risk adenomas may not require endoscopic surveillance. Our aim was to assess which specific adenoma attributes related to a higher risk of development of metachronous colorectal cancer or advanced lesions and therefore required endoscopic surveillance. In order to do so, we performed a systematic review and meta-analysis where our main outcomes were incidence of metachronous advanced adenoma, incidence of metachronous colorectal cancer, and colorectal cancer mortality. We established different risk categories and assessed the outcomes in each one of them. Based on these recommendations recently published in gastroenterology, we formulated different PICO questions, where the population was the different risk categories, the intervention was colonoscopy, the outcomes were the one that I previously mentioned, and we established different comparators, such as patients with non-advanced adenoma, population with normal colonoscopy, or general population. We performed a literature search in the databases of PubMed, the Cochrane Library, and InBase from inception to July 2020. No publication date or status restrictions were applied, and language was restricted to English, Spanish, and French. We included cohort studies, case control studies, and clinical trials, and excluded those studies which included patients younger than 18 years with any high-risk condition for colorectal cancer or a personal history of colorectal cancer. And also, we searched related articles of meta-analysis for eligible studies, which we refer to as cross-references. The initial search returned 4,946 studies, of which 4,599 remained after the application. After applying inclusion and exclusion criteria and adding the cross-references, we selected 174 studies for full text assessment, and finally 68 studies were included in the statistical analysis. Of those, 63 were cohort studies, 2 were case control studies, and 3 clinical trials, with a total of 731,040 patients, with a mean age of 60 years and 63% of males. The mean duration of follow-up was of 5.1 years. We calculated the colorectal cancer incidence per 1,000 person years for each one of the risk categories. And as you can see in the table, it was 2.0 for the category of advanced adenoma, 1.3 for high-risk adenoma, 2.6 for adenomas of 20 millimeters or more, 1.6 for adenomas of 10 millimeters or more, 1.2 for 5 or more adenomas, 1.4 for 3 or more adenomas, 2.1 for villous component, and 2.8 for high-grade dysplasia. Now I'm going to present the pooled risk ratios for each one of the risk categories. As you can see in the presentation, the pooled risk ratio for colorectal cancer incidence when comparing patients with high-risk adenomas versus those with non-advanced adenoma was 2.21, and when compared with patients with normal colonoscopy, 2.72. Also, for this specific risk category, we were able to calculate the pooled risk ratio for colorectal cancer mortality, which was 2.34 when compared with patients with non-advanced adenoma and 2.62 when compared with patients with normal colonoscopy. As for adenoma size, the pooled risk ratio for colorectal cancer incidence when compared patients with adenoma of 20 millimeters or more versus those with adenoma smaller than 20 millimeters was 3.09. When comparing 20 millimeters or more versus 10 to 19 millimeters, 2.08. When comparing 10 to 19 millimeters versus less than 10, 1.73, and when comparing 10 or more millimeters versus less than 10, 1.62. In this final comparison, we did not reach the statistical significance. As for adenoma number, we calculated the pooled risk ratio for colorectal cancer incidence, comparing 5 or more adenomas versus less than 5, 5 or more versus 3 to 4, 3 to 4 versus less than 3, and 3 or more versus less than 3, but we did not reach statistical significance in any of the cases. However, things changed when we estimated the pooled risk ratio for advanced adenoma incidence, which was 2.39 when comparing patients with 5 or more adenomas versus less than 5, 1.64 when comparing 5 or more adenomas versus 3 to 4, 1.86 when comparing 3 to 4 versus less than 3, and 2.72 when comparing 3 or more versus less than 3. As for villous component, the pooled risk ratio for colorectal cancer incidence when comparing with patients with tubular adenomas was 1.75, and when comparing with patients with normal colonoscopy, 3.58. And finally, for high-grade dysplasia, the pooled risk ratio for colorectal cancer incidence was 2.94 when compared with patients with adenoma with low-grade dysplasia, and 6.62 when compared with patients with normal colonoscopy. Finally, we calculated the absolute risk reduction and the number needed to scope for colorectal cancer incidence in each one of the risk categories compared with patients with non-advanced adenoma and normal colonoscopy. As you can see, the number needed to scope are relatively high, but are the lowest for the categories of advanced adenoma, size of 20 millimeters or more, and high-grade dysplasia, and were the highest for patients with 5 or more adenomas or 3 or more adenomas. So, to sum up, metachronous colorectal cancer risk is significantly higher in patients with baseline adenoma with high-grade dysplasia, villous component, or size of 10 millimeters or more, which supports an indication for surveillance in this population. However, multiplicity does not seem substantially related with a higher risk of colorectal cancer, and therefore these patients may not benefit from endoscopic surveillance. Thank you very much.
Thank you for that great presentation. It's now my pleasure to introduce Dr. Roland Valori, a world-renowned leader in colonoscopy quality improvement from Gloucester, UK. He served as the National Clinical Director for Endoscopy in England for over a decade and has been involved in numerous other leadership roles. He has a strong interest in improving colonoscopy training and in preventing post-colonoscopy colorectal cancer. So it's perfectly appropriate that he's presenting this talk entitled Post-Colonoscopy Colorectal Cancer Auditing from the UK. Welcome, Roland.
Thank you very much, Jason. Can you see my screen?
Yes, we can.
Yep.
It's not in the large mode, though. We're seeing the small slide off to the side.
Okay. So, but you can see the slides okay?
Yeah, it's a bit small. If there's a way for you to switch to the presentation mode, the actual slideshow itself.
Hang on a moment. So
that's perfect. Yes.
That's perfect. Okay.
We see the early report slide.
Early report of national PCRC audit. Is that right?
Yes, that's right.
Okay. So we in this study are addressing statement 4 of the recent WHO consensus recommendation, particularly the first 3 aspects, identifying cases, explaining why they've happened and what needs to improve. And this is a very early report of a national audit tool. What we've done is created a process for identifying PCRCs, a portal with an audit template. We've tested it in 12 hospitals. We're doing this primarily as a quality improvement exercise, but inevitably there are some data outputs, and that's what I'll be sharing with you today. We identify the PCRCs by combining the hospital episode statistics database with a registry, and this gives us the PCRC 4 years. Interestingly, up to 20% of these cancers are diagnosed in a different hospital, and I would expect in a less integrated health system, this could be much higher. We've created an audit template, which is largely based on the recommendations in the WHO consensus statement, particularly this categorization, which looks at whether an adenoma was seen in the affected segment and whether the prep was good or not, and whether the lesion was resected. But in our report in gastroenterology last year, we emphasized that it's not just about finding and removing adenomas. There are other factors that are important, particularly patient factors, clinical decision-making, administrative factors, and our processes for surveillance. And certainly in my own hospital, there were major shortcomings in the surveillance process of IBD patients, which I suspect is the case elsewhere. If we drill down to the patient factors, there's something about their biology, their preferences. They don't always want further tests if the test has been incomplete. There are issues about procedure and comorbidity. And I think most would agree that these 4 groups of patients are at increased biologic risk. And we've just heard about those who have polyps. So we identified patients over the age of 18 in the registry using those codes and the colonoscopy with the code as identified there. And we know that some of the colonoscopies are not fully captured in the hospital episode statistics. So we looked at our national bowel cancer screening data set as well. We had 12 hospital sites, which were a mixture of large, small, teaching, non-teaching, spread across the country. Information governance is a big issue here because basically we are feeding patient identifiable data into the hospital test sites. And we went through a very long process to satisfy the cancer registry that we would minimize any risk of data leaks. An early version of the website looked a bit like this, and there are a series of questions and statements that people had to answer for each case. So what about the data outputs? Well, first of all, the indications for the index colonoscopy, and about half were for investigations of symptomatic patients, and some were for other reasons, particularly surveillance. And if we drill down to the surveillance, we see that most of the surveillance reasons for the index colonoscopy were related to polyp surveillance. The second, or the first percentage column here is the absolute percentage of cases, and the second is the percentage of the surveillance cases in these categories. There are a total of 142 patients in this very preliminary report. So who did the colonoscopy? Well, here's a list of the colonoscopist types. We mustn't read too much into this because we don't have the, that should say the denominators, not the numerators. We don't know what percentage of colonoscopists are done by gastroenterologists, etc. in the nation. And some of these groups will be scoping the higher risk patients, particularly IBD surveillance, and polyps will largely be done by gastroenterologists. The age profile of these patients was much as you would expect, as was the sex profile. We asked for a categorization of interval and non-interval cancer types based on the WHO recommendation. And the point here is that certainly in our country, and I suspect many other countries that don't have colonoscopy-based screening with 10-year intervals, that only 15% of all our post-colonoscopy colorectal cancers were categorized as interval cancers. What about the WHO categorization? Well, you can read here for yourself, the majority were category A, which is a possible missed lesion, examination adequate, but there are a significant number of lesion detected but not resected, and some of these may be because of patient preference or comorbidity or other factors, and some incomplete resections. So what about the non-WHO factors? Well, if we look at patient factors, more than 10% of cases, there was an important patient factor in the development of the post-colonoscopy colorectal cancer, particularly failing to turn up for tests or declining further tests when they're recommended. And I would regard these to be largely unavoidable post-colonoscopy colorectal cancers. In contrast, we have administration factors, booking delays, or failure to booking in 10% of cases, and these are certainly avoidable factors. And decision-making factors, we were asking for evidence of decisions, for example, repeating procedures when lesions had found, or when prep was inadequate, or the procedure was incomplete. And there was significant failings here in nearly 20% of cases. If we combine all those, we see there's a bit of overlap, but the take-home message is that a third of the PCRCs in this very preliminary report were unrelated to the quality of the procedure. We also looked at procedural factors, and I emphasize here these were factors that were mentioned in the endoscopy report. So if they're mentioned in the endoscopy report, usually they're regarded, or I would regard them to be quite important and take notice of them if I'm repeating a colonoscopy or deciding whether one needs to be repeated. We can see that in a third of cases, there were difficult procedures for one reason or another. And I think when procedures are difficult, the endoscopist is more stressed and more likely to miss stuff. What about the site of the cancer? Well, we're comparing the sites here in our audit, 142 patients and the general population. And to make this a bit easier to see, for the cancers in the audit in the lower bowel, they were less frequent than those seen in the general population. Double or more in the sort of upper left colon transverse, and slightly greater on the right side of the colon. Now, we've only got 142 cases here, but we're going to roll this project out across the nation, and we'll soon gather hundreds, if not thousands of cases, and have a much more accurate picture of whether this pattern is consistent. We looked at completion, documentation, and particularly whether a photo had been done when we considered completion to be important, and it was there was a photo, an adequate photo, in only 62%, and only 50% of patients with rectal cancer had an adequate photo of the rectum at the index colonoscopy, and we can do much better than this. I think it's fair to say that these cancers were cancers which came after index colonoscopies between 2014 and 2016, and things have definitely improved since then. What about staging? Well, interestingly, in the audit, we saw more early stage disease and actually quite few stage 4 disease compared to the general population. What about site and stage versus delay in diagnosis? Well, this is a scattergram of size against delay. And basically, there's a random scatter there, both in terms of size and staging, I would say. In our report in gastroenterology, we suggested that if there was a growth rate of less than 5 millimeters a year, it would be unfair to expect the lesion to be seen at the index colonoscopy. And when we look at the staging of these smaller cancers here, all bar one are stage 1, and there are 2 stage unknowns here. But I think we can probably say these are unavoidable and not of great impact for the patients. So in conclusion, we have a process for identifying PCRCs for individual hospitals. even if that cancer was diagnosed in a hospital that was different, far away from the hospital where the index colonoscopy was done, providing the cancer is diagnosed in England. This is a study just for England. We have an auditing template for these post-colonoscopy colorectal cancers, which guides the person, the individual, to what they need to be looking at and what they need to focus on in terms of improvement. So the next steps, the purpose of the 12 hospitals was really to assess whether the audit tool was fit for purpose, whether it needed to be improved, and a number of suggestions were made, and we have specified what they need to be, and the site is being reprogrammed. We will start rollout probably in September of this year, and give the nation a couple of months to audit their cases. We expect each site to have between 5 and 20, 25 cases to audit. We'll be looking at data in early next year, and we should have a report for this meeting if it was deemed appropriate. We need a sustainable solution here, and the plan is to integrate it into the accreditation of endoscopy services. So it would be a requirement to maintain accreditation. And I know that our regulator is very interested in this sort of audit, and will use it as a marker of good performance. We've put in a grant to duplicate this tool for upper GI cancer, pancreatic cancer, and also CTC for bowel colorectal cancer. So I'd like to acknowledge all the members of the project team. All of these individuals have put some significant input here. These are the organisations involved, and a particular thank you to the charity Bowel Cancer UK that have funded this project. Thank you very much.
Thank you very much, Roland. And the next talk is entitled, "Is colonoscopy less effective in the right colon?" It's given by Ulrike Haug. Ulrike is a professor of clinical epidemiology and pharmacoepidemiology at the University of Bremen, Germany, and head of the Department of Clinical Epidemiology at the Leibniz Institute for Prevention Research and Epidemiology. Please, Ulrike.
Thank you, Rolf, for the introduction, and thank you to the organizers of this meeting. So, the title of my talk is "Colonoscopy Less Effective in the Right Colon?" And just first to clarify, in the next minutes, I will talk about relative effectiveness of colonoscopy, not about absolute effectiveness, just to avoid confusion. Now, you may be surprised why I'm asking this question, because it seems there is already consistent evidence from observational studies suggesting that colonoscopy is less effective in preventing right versus left-sided CRC or CRC death. So there is evidence from case control studies showing a big difference between left-sided and right-sided CRC. But there's also evidence from core studies that are typically considered to have a higher level of evidence, like a recent study from Wu et al., which showed a 64% incidence reduction for left-sided CRC, but only half its effectiveness for right-sided CRC. So despite this consistency in the evidence, I still think it's worthwhile to ask the question or to question these findings, because there may be unrecognized self-inflicted biases in existing observational studies. So with self-inflicted, I mean biases that are somehow imposed by the study design, so unintentionally. And in the first part of my talk, I will explain this in more detail, these self-inflicted biases, how they could occur. And in the second part, I will show you first results of a study that avoided these types of biases. Now, let's start with the explanation of self-inflicted biases. I use the example of a cohort study here, but for didactical reasons, I would like to start explaining this based on RCT, because there is more, it's clearer, it's more obvious. So imagine the following RCT. So you randomly assign persons to the colonoscopy arm or the control arm. Persons undergo colonoscopy, and you will find some CRCs at baseline, others will occur during follow-up. So at the end of the day, you compare the cumulative CRC incidence between both groups, and determine the effectiveness of colonoscopy. Now imagine the PI of the study would decide that screen-detected CRCs should be excluded. So this would artificially lower the cumulative incidence in the screening arm. Of course, this would be a flawed design. I think this is quite obvious here. And the result would be that the effect of colonoscopy is overestimated. So this should not be done. I think this is clear. Now, let's translate this now to observational studies. As you know, assignment to the groups here is not done by random, but persons assign themselves to the group. So they are asked if they had a colonoscopy in the past. And if yes or no, this then is the groups, the colonoscopy group and the control group. Now, in this type of study that I'm now explaining, the second step was that persons were asked if they had a CRC in the past. Prior CRC, which not surprisingly occurs more often in those who already had a colonoscopy, because colonoscopy leads to CRC detection. So, and these persons also were excluded. And now this is similar to the picture we have looked at before, and also the consequences are the same. If you now determine the cumulative CRC incidence in both groups, then you will overestimate the effect of colonoscopy. So the study design is also flawed. This has nicely been described by Miguel Hernan's group in 2017 already. But my point today is that this type of bias does not equally affect left and right-sided CRCs. So the mainly affected CRCs are left-sided. So this is where the overestimating is then mainly relevant. And why is this the case? Of course, you know that the vast majority of CRCs detected at the typical starting age of screening are in the left-sided colon, whereas newly growing CRCs, newly growing at older age, are more often in the right colon. So these excluded cancers at baseline are mainly in the left side, and thus the cumulative incidence for left-sided CRC is artificially lowered. Now, the fact is now that these self-inflicted biases in existing observational studies mainly affect left-sided CRCs. They lead to overestimating the effectiveness of colonoscopy for left-sided CRC. And consequently, this leads to a seemingly high difference in the effectiveness of colonoscopy for right versus left-sided CRC. With this, I would like to go on presenting the results of a study that tries to avoid these types of biases. And this is the so-called target trial approach, which has indeed been described by Miguel Hernan's group and also applied based on Medicare data by Garcia Albanese et al. In 2017 for colonoscopy. So the core part of this methodology is that it tries to be as close as possible to randomized controlled trials, and especially to avoid that eligibility is assessed at another time point than when the treatment is assigned. Now, for this study here, we use the German claims database that covers 20% of the German population. We included persons aged 50 to 69 years and used exclusion criteria similar to RCTs as far as it can be assessed in claims data. We sequentially emulated trials starting each quarter from 2007 to 2011. And then, so there was the available follow-up data, it was possible to estimate the effect of screening colonoscopy on the 11-year risk of overall right-sided and left-sided CRC. We adjusted for baseline confounders using inverse probability treatment weighting as far as confounder information was available in the data. So we considered, for example, age, sex, education, obesity, diabetes, and so on, so along this tier. Now, I already come to the results. The first, the group size. The screening group comprised about 200,000 persons, and the control group comprised 350,000 persons. The mean age in both groups was about 61 to 62 years, and 50-54% were female. Now, in the screening group, there were, considering both baseline and follow-up, 1,564 CRCs, and in the control group, there were 2,541 CRCs. The distribution by side was more or less similar in both groups, so 2/3 in the left side and about 1/4 in the right side. So on this slide, I show you the adjusted cumulative incidence curves for left-sided on the left-hand side and for right-sided on the right-hand side. So at first, it's eye-catching, of course, that the cumulative incidence is higher for left-sided CRC, but this is not surprising, so I would not focus on this now, that the relative difference, relative effectiveness is different. But so of interest here is the absolute, so the relative effectiveness here is the focus here. So the absolute effectiveness, of course, different, but we focus on the relative effectiveness here. So we calculated a relative risk of 0.64 for left-sided CRC and of 0.73 for right-sided CRC. So a difference of 9 percentage points between both, and the confidence intervals were largely overlapping. So only a minor difference, if at all. Now, what is also interesting here is to look at the points where these curves cross. So here for the left-sided CRC, they already crossed at 6 years, but they crossed later for right-sided CRCs at about 7.5 years. I didn't show the sex stratified curves here, but so these curves even crossed later in men than in women. So in conclusion, the emulated target trial suggests that there is only a minor, if at all, difference in the relative effectiveness of colonoscopy in preventing left versus right-sided CRC. And it also showed that measuring the preventive effect in the right colon requires a longer follow-up, particularly in men. So this has to be taken into account when planning studies in this field, but also when interpreting cancer registry data, for example. It has to be acknowledged that confounded information in claims data is suboptimal, but looking at the effect of adjustment in other studies suggests that this only played or did not play a major role here. So the findings I presented here from this target trial are in contrast to existing observational studies, which suggested a big difference regarding effectiveness of colonoscopy for right versus left-sided CRCs. But there's also evidence that supports that there is not a huge difference, like a recent reanalysis of individual-level tandem colonoscopy studies found no higher miss rate for left versus right-sided adenomas. But still, there could be biological differences between left and right-sided lesions, faster-growing tumors. Still, I do not believe that the difference is as huge as suggested so far, because this presence of self-inflicted biases in existing studies on this topic is likely, which led to a seemingly high difference in the effectiveness for right versus left-sided CRC. Now, I only explained this biases for a certain type of core studies, but there are similar biases in other study designs that suggested a huge difference. So with similar consequences that they overestimated this difference. I do not have the time to explain this now, but we'll do this in a separate paper then. So now I would like to thank you for your attention, and I'm looking forward to questions later on.
Thank you very much for that fascinating presentation, Dr. Hogg. Our final presentation during this session is from Dr. Rutter. He is a professor of gastroenterology at Newcastle University and the University Hospital of North Tees in the UK. He's an internationally recognized leader in endoscopic quality improvement and chairs the UK Bowel Cancer Screening Program Research Committee, the WEO Interval Cancer Subcommittee, and has many other leadership roles. Today, Dr. Rutter is going to give us a presentation entitled Analysis and Categorization of Post-Colonoscopy Colorectal Cancer Using the WEO Guidelines. Welcome, Dr. Rutter.
Thank you, Jason. So let me just share my screen. Okay, so yes, I'm going to go back to the topic of post-colonoscopy colorectal cancer. My slides are not moving on. There we go. So I have no conflicts of interest, but people to thank, because many people have contributed to the WEO work on interval cancers and post-colonoscopy colorectal cancer. During my presentation, I'm going to briefly go back to the interval cancer and PCCRC work that WEO has done, looking at terminology. And then I'm going to focus on the different types of PCCRC analyses, because I think these do cause some confusion. And I'm going to illustrate that with a recent piece of work that we've produced from our centre, which is available online now in Endoscopy Journal. But I'll start with the gut publication. This is the WEO's piece of work led by Silvia Sandolinu, developing an internationally standardized definition and taxonomy for interval cancers. And through this piece of work, an interval colorectal cancer was defined as a colorectal cancer diagnosed after a screening or surveillance exam in which no cancer has been detected and before the date of the next recommended exam. And that's a fairly standard definition for interval cancer. And then roll forward 3 years, and as Roland mentioned, we published in Gastroenterology a piece of work looking at post-colonoscopy and post-imaging colorectal cancer. Now, I think in many people's minds, they think that PCCRC and interval cancer are interchangeable terms, but clearly that's not the case. On the simplest level, of course, interval cancers don't always relate to colonoscopy. You can have fit interval cancers. But if we focus on colonoscopy, there are many differences, but perhaps the most important one is that an interval cancer is a cancer occurring between two screening tests, whereas a PCCRC includes cancer detected at the next procedure. So let me illustrate that. Let's take a 60-year-old patient who comes for the English screening program. They have a FIT test, it's positive. They have a colonoscopy, it's normal. Now in our program, they're then re-invited for a FIT test 2 years later. And again, they prove to be FIT positive. But on this colonoscopy, a colorectal cancer is detected. Now, from a screening perspective, this is a screening detected cancer. This is a screening success. And by definition, it's not an interval cancer. But the endoscopists in the audience will appreciate that this is a post-colonoscopy colorectal cancer. It's highly likely that something occurred during the first procedure, something was overlooked, and therefore there's a potential quality assurance issue. Now, in the WEO gastroenterology paper, we described 3 separate analyses. The first is the PCCRC rate. This is the one that has had the most research done subsequently. And this requires a large scale analysis, high level data, looking at tens of thousands of colorectal cancers. And it gives us an overall assessment of the quality of a colonoscopy within that service. But I'm going to focus on the other 2, the individual case or root cause analyses, as Roland did in his presentation. I'll touch briefly on the most plausible explanation, in other words, why this PCCRC might have occurred. And then I'm going to focus mostly on the interval and non-interval subcategorization, which gives us a clue as to the appropriateness of or adherence to guidelines or a screening program. So I'm going to use this paper to illustrate those analyses. So we, in our hospital, and these are local level analyses, took 2 years worth of colorectal cancer diagnoses and then did the subsequent analyses. So to cut to the chase, we had 527 patients with colorectal cancer, and 48 of these were post-colonoscopy colorectal cancers. In other words, they'd had a prior colonoscopy, and we looked all the way back to up to 10 years prior to the cancer diagnosis. The median age was 73, 44% were female, 10% of these were seen in high-risk patients, so inflammatory bowel disease or genetic predispositions. 65% of the preceding colonoscopies were done for symptoms rather than screening, and 52% of the PCCRCs were seen in the proximal colon. So to look at the most plausible explanation, and Roland showed this too, but essentially you take the time of the cancer diagnosis and then you look at whether the interval from the previous colonoscopy was more than 4 years. And if it was, then we call these likely new cancers. And in our study, 33% of the cancers fell into that category. Now, Roland's piece of work excluded those, and he just focused on the other 4 categorizations. So let's work through those. So if the interval from the previous colonoscopy was less than 4 years, you look at whether there was an advanced polyp in the same segment, and if so, was it resected? And if it was, then the conclusion that it's likely that this was incomplete polypectomy. And actually in our series, no patients fell into that category. If there was an advanced polyp, but it wasn't resected, then these are categorized as detected polyp, not resected, and 6% of our PCCRCs fell into that category. If there's no advanced polyp in that segment, and we actually did a sensitivity analysis looking at the adjacent 2 segments, then you look at the quality of the procedure, cecal intubation, adequate preparation, and you can subcategorize missed lesions into adequate exam, 44% in our study, or inadequate exam, 17% in our study. So overall, you can see that over half of our PCCRCs were due to missed polyps. Let's move on to look at the other type of categorization. And I'll talk you through this. So essentially, some people will have a colonoscopy and then there'll be no plan for a subsequent colonoscopy. So in our country, if you have a symptomatic colonoscopy with nothing found, we don't recommend subsequent colonoscopy. So if a cancer then occurs, these are categorized as non-interval type C type PCCRCs. But for people who have a planned subsequent procedure, if the cancer occurs before that planned date, they're categorized as interval type cancers. If it occurs at the subsequent procedure, they are categorized as non-interval type A PCRCs, excuse me. And if it occurs after the planned date of that recommended screening or surveillance interval, then they're categorized as non-interval type B. And each of these has potential different implications. So let me talk you through those. So just as in Roland's wider piece of work, we had 15% of our PCCRCs being categorized as interval type. And again, I want to stress the point that we really shouldn't therefore be using those 2 terms interchangeably. But what does this mean? Well, essentially, these lesions will occur either because the interval is too long, inappropriately long, or perhaps more likely, the baseline quality of index colonoscopy has been suboptimal. 12% of our PCCRCs occurred at the time of the next procedure, so they're type A non-intervals. And again, the implications are very similar to interval type cancers. But as I mentioned earlier on, unlike with interval cancers, these are potentially still considered successes, particularly if they're early cancers, and especially with rapidly growing cancers such as IBD or in Lynch syndrome. So I think it's important that they are categorized separately. From a local perspective, it's the type B cancers, however, that I think are the most relevant. So these are ones occurring after the intended screening interval, and these indicate suboptimal adherence to guidelines. Now, there can be a number of reasons for this, as Roland alluded to. It can be clinician driven, so the clinician may not be aware of the guidelines, or there may be some deliberate decision to deviate from the guidelines. It can be patient driven. The patient may decide not to come back for their procedure, or it can be due to administrative error with the patient not being recalled as anticipated. And then finally, we have our type Cs, and 42% of our PCCRCs were type C, where there had been no recommended and planned subsequent interval. So very briefly, lessons learned. Well, I think we demonstrated through our work that it's very feasible at a local level for people to do this. It's actually quite quick to do. It takes 5 to 30 minutes per case. We showed a decent inter-observer agreement with both of these analyses. And I think if you have a single clinician doing it and you have a panel review for the complex cases, it's very easy to do. The other point that I want to make is that people get confused with PCCRC rate methodology, and that's high-level work. We have to make some pragmatic decisions as to time intervals for that. That's very specific for PCCRC rate. You have to think of these root cause analysis work as being entirely separate, and we don't therefore need to apply the 6 to 36 month cutoff. So please do bear in mind there's very separate analyses. So to summarize, we think it's very feasible for this to be done at a local level. In our study, the majority of PCCRCs were due to missed lesions, so that's probably where the value is in terms of quality improvement. We've demonstrated quite a high level of non-interval type B PCCRCs, again showing that a significant proportion of our cancers could potentially be avoided if we adhered better to the recommended surveillance intervals. And I'd like to thank you for your attention.
Thank you, Dr. Rudder, for that wonderful presentation. I'd like to invite all of our presenters to turn on their cameras and might have their microphones ready. We have a few questions from the audience. I can start. Sandra, there was one question for you about the implications of your study. The influence of publication date on the outcomes that you found. Was there any difference between earlier studies and later studies for your findings?
Well, thank you very much for the question. We are currently performing different sensitivity analyses, and one of them is about the date of publication or patient inclusion, but we do not have the results yet, so we will have to wait for it. Thank you.
I wonder if you could, go ahead.
Sure, sorry. I missed that question, it disappeared for me. But then for Dr. Haug, what are some of your recommendations for best practices for cohort studies of colonoscopy outcomes?
Yeah, actually analyzing, using a target approach to a target trial approach to analyze them. But I'm aware that this will not be possible for all cohort data. So it's some requirements that you need to know from in terms of date of colonoscopy, date of prior CRCs, and so on. I see the point that I think there's another question on how to develop guidelines, how to consider this could be considered. And I would also suggest that we could somehow make a small group that writes down what is important to consider for those conducting these studies, but also for reviewers reviewing these studies. Because this is something that is also among epidemiologists just kind of getting more and more disseminated, and I think we should also be on top here in this group.
Yes, and that was also a suggestion from Samir that the WEO should convene such a group. So I guess you should discuss that in the future. So over to you then.
Yeah, thanks. Sticking with Ulrike, the incidence reduction that was seen with colonoscopy was less than what is commonly expected with colonoscopy. Does that concern you, that your findings seem to be different in that regard? Or do you have
Well, it depends on what you compare it. If you compare it to results of prior cohort studies, then my point is more that they overestimated the effect. So we haven't seen the results of RCT yet. It will be exciting to see the results of the Nordic trial. And we will also do analysis limiting to the age range of the Nordic trial, just to have kind of projection what they might find. But in my eyes, this is plausible also because the effect in the proximal colon, as I've shown, will occur later. So we haven't seen the full effect yet for the proximal colon. At 11 years seems not to be enough. And the curves showed that this the brain effect starts growing in after 11 years. So in my eyes, but as I said, it's difficult to find good data to compare with.
Yeah, and Dr. Schoen asked about the time frame for the curves crossing. In the FLEX-SIG trials, they tend to cross earlier, more in the 3-year range than in what you're seeing in your study. I think it was around 6 or 7 years. Any comments on that?
So maybe I have it, I do not remember correctly, but there could be some differences in the curves crossing, but it was more or less similar. What was the point here for the RCTs? Because they didn't cross after 3 years, I think, in the SIG trials.
Okay.
Did I misunderstand you here?
Yeah, that's what Dr. Schoen had written in his comment. Perhaps Rocky would like to turn on his microphone and clarify. Give him, here he comes.
Yes, in the PLCO trial, for example, the curve started to cross at 3 years. And I believe that was like that with the UK trial as well. So it just concerns me because this is kind of a modeling exercise. And if the curves are crossing at different time period, it raises questions whether the model is accurately representing real world data.
Mm-hmm. I mean, yeah, this has of course been, one has to assess what the reason could be. There are of course some differences. So this is not identical to RCTs. And one also has to take into account what the baseline incidence has been. So this also will influence when the curves can cross. So I think we will then further discuss this, also comparing the baseline detection rate.
Thank you very much. I have a question for Roland and Matt both. Matt, you touched on the time required to do these audits. I was going to ask Roland, about that. I work in the VA system and we put out quality metrics and ask people to do work like measuring ADR. And I get a lot of pushback where people say, this is an unfunded mandate. I wonder if you can comment on, how easy it is to roll out these kinds of requirements and the time work, the work required to do this auditing.
Yeah, I mean, our study was, that was one of our secondary aims, was specifically to look at that, at the feasibility. And we provide a series of cases for the grey areas. I didn't have time to talk about that during my presentation, but we tried to illustrate where it can be challenging. Yeah, on average, it takes about 5 minutes for the straightforward cases. And that's using data that's readily available. For the complex ones, it can take up to 30 minutes, but that's not for most. And we found that actually one person can do this, and just a small proportion of cases, you might want to make some sort of panel consensus decision as to what the right categorization is. But by and large, it's pretty straightforward to do.
Yes, you have a form for it, which you just send out, or how does it work?
So we did that within our hospital. So we didn't use a form. We set up a spreadsheet. So I guess effectively it was an electronic form. And then one of my research fellows, David Beaton, looked through the data for these cases just from our hospital electronic data sets that we have, the endoscopy data, the pathology data. And that provided most of the information, and rarely did we have to look much further than that. So it is pretty straightforward to do.
So can I come in there and just add to that? So firstly, I personally reviewed over 150 of these cases, and we had 6 meetings with our pilot sites, and we asked them specifically how difficult it was. And how difficult it was largely dependent on the data on the information systems. So a lot of English hospitals still have paper records and Polaroid pictures stapled to paper records, and if you have that sort of system, one of my patients, for example, had 4 volumes of notes for the record, and that's very time consuming. And as Matt said, some cases are a little bit more complicated. But I think as we have more widespread EPR and better image capture, etc., this is a very quick thing to do. The second thing I'd say, Jason, is that I've usually done this with trainees in gastroenterology, and this is a hugely valuable learning exercise for them, assessing adequacy of photographs, assessing lesions, discussing interval times, discussing decision making, etc. It's very, very rich learning. And so we're encouraging trainees to do this and do, as Matt said, is do the initial data gathering and then present the case at a forum. where you can get help with the judgments.
That's great. Matt, when you said you had a research fellow doing that, is that a physician doing it or a non-physician?
A physician, yeah, and endoscopist.
I think it has to be an endoscopist doing it, really, Jason, as a minimum.
Okay, there's a question from Nero Sagnon. The overall impact of total colonoscopy on incidence according to correction for self-inflicted viruses would be lower than expected. I don't know who will answer that. Any volunteers?
I think that was directed at Ulrike.
We've already answered that one.
Oh, you answered, okay.
Yeah.
So I didn't understand, Greg. So the overall effect of colonoscopy was lower than expected. Yes, this is my estimate based on what we have done. And that it also takes longer to measure the full effect. So once the first trial data will be published, this might not be the end of the full effect, because for proximal cancer, where colonoscopy could add to colonoscopy, this would take longer to measure than the effect. But there's also the problem of then the competing events. So if the effect occurs so late in life, then we have also taken into account that persons might die before the effect can occur. So this is another thing that has to be considered if there is a delay in this effect in the right-sided colon.
And I have one last question for Sandra. Your study is very interesting, and there's been new guidelines in the U.S., for example, came out a little over a year ago. What do you think are the implications of your study for future guidelines on colonoscopy surveillance?
Well, we think that the main highlight points are the lower risk of multiplicity. Along with our results, there are recent studies that also show that. So maybe that's one thing to consider. And well, another point that is a little controversial with the recent results is the paper of velocity that we will need to keep checking into that. So there are some points that are getting more clear, but there are still some things that need to be looked at better.
Thank you. I think that's it for the questions that we have from the audience. So thank you all for a wonderful session and great discussion. We're going to move for the break now, and please pay attention to the comments from our sponsors. We have some announcements from our sponsors during the break. And Alexandra, how long is our break this time?
We will take a 10-minute break.
Thank you, everyone.
Thank you.
Welcome back to session 4.
Well, I think that we can start now. We welcome.
Absolutely. Please go.
We go?
Yes, please go ahead.
Okay, so welcome for this last session. It's a very important one because the topic is about the blood biomarkers and a multi-cancer screening approach, which is really something important and new. And I have the pleasure to share with my colleague, Professor David Ransoff from North Carolina University. I work in Paris at La Sorbonne University, and our first speaker will present us the last studies available. Robert Schoen is a professor of medicine at Pittsburgh University. He is very welcome by his previous work on prevention. It's a pleasure to present him as a friend and as the best of the expert. Thank you, Robert.
Thank you very much. I'm going to talk about blood-based screening for cancer detection. These are my disclosures. As cancer cells turn over, they can release their DNA into adjacent media. There's a wide variety of proximate fluids that could be assessed for circulating tumor DNA. And I want to make the point that we're looking for mutations that are somatic mutations within driver genes that are responsible for clonal growth. There are other targets beyond circulating tumor DNA in the blood, such as epigenetic changes, proteins, and even how the DNA is fragmented. I want to make a distinction between cell-free DNA and circulating tumor DNA. The vast majority of DNA that is circulating in the blood is cell-free DNA from hematopoietic cells. In both instances, they arise from apoptosis. We don't really understand the etiology of the level or amount of circulating tumor DNA that is in the serum, for example, or in the plasma. And that is, it's not necessarily proportional to tumor size or stage, though generally it is so, and it does vary by tumor site. There are 3 big challenges for ctDNA as a biomarker. The first is sensitivity. There can be as little as 1 mutant molecule per milliliter of plasma, and most of these studies are done with large volume plasma, like 7 or 10 cc's. There's an issue of specificity. There are other sources of mutant clonal DNA, such as CHIP, which is clonal hematopoiesis of indeterminate potential, which is something that arises from the bone marrow. Then there is the issue of tissue of origin. If I find a circulating KRAS mutation in your blood, I don't know, is that a pancreas cancer? Is that a colon cancer? Is that a breast cancer? The same mutations appear in many different cancers. Now, all of this is kind of evolved from the revolution in digital genomics, which allows us to amplify DNA and then characterize between a wild type, between a true positive mutation where the mutation is seen in nearly all the strands that are amplified, as opposed to a replication error. One big question that the industry and the community face is it better to develop a test that seeks to identify multiple cancers, or should we take a blood test and try to develop one for each type of cancer? For example, GRAIL, which is pursuing pan-cancer testing using targeted methylation, they are detecting more than 50 cancers. That's their intent. There are challenges to pan-cancer testing. First of all, there's always this concern about specificity, the unintended consequences of a positive test and workup and other things that could ensue. Furthermore, each cancer has its own idiosyncrasies. For example, we know screening is efficacious for colon cancer, for breast cancer, for lung cancer, but we don't know if it's effective for pancreas cancer. There's an issue of workup burden. If you have a positive test that's leaning you towards ovarian cancer, it could end up with a laparotomy as opposed to a colonoscopy for colon cancer. And we do know, as I said, that circulating tumor DNA does vary by tumor site. Now, there is a big benefit to pan-cancer testing, and we've touched on this actually throughout the day. And that is, if you're looking for more cancers, you have a higher population prevalence that you're searching for, and that leads to a higher positive predictive value. So a greater likelihood that a positive test means that a cancer is present. With colorectal cancer, I see specificity as less of an issue. If a blood test shows a false positive and it sends you to a colonoscopy, that's not that much of a concern. We have many countries like our country that use colonoscopy as the primary screening test. These are like the four major industry people that are involved in blood-based screening right now. And I call your attention, A, that they use some different methodology in terms of detection, but B, look at the amount of money that has been devoted to this, billions of dollars really. So there is a big movement to push these technologies. I'll make the point just to presage what Carlo's going to talk about. With the colorectal cancer test, that is a blood test just for colorectal cancer, that fits very nicely within our multiphasic approach for evaluating new tests. But when you have a pan-cancer test, that really changes the playing field, and Carlo will address that. These are the two colorectal cancer-focused, blood-based, like FDA registration trials that are currently in play, Freenome and Garden, and you can see the N that they're planning to recruit. One big question about the blood-based cancer screening tests is how will they be at detecting advanced polyps? For example, in the PLCO trial, 2/3 of the mortality benefit is estimated to be due to prevention. That is, if you don't get a cancer, you don't die from the cancer. And if these blood tests are good at detecting cancer, but not so good at detecting advanced adenoma, they're not going to shore up very well from a prevention standpoint. I wanted to, in my last couple minutes, take you through this study, the DETECT-A study, because that's the largest pan-cancer study that's been done, and I think there's a lot of interesting data from it. So this study set out to answer 4 questions. These are the 4 questions. Can a multi-cancer blood test detect cancer? Can it intervene or affect cancer progression? Can it not interfere with standard of care screening? And can it be performed safely without incurring a lot of futile or dangerous workup? So this was the schema that they used. They did a baseline test looking at circulating tumor DNA and proteins. If the test was positive, they did a confirmation test. They ruled out CHIP, and they insisted that the exact identical mutation was found again. If then both these tests were positive, they generally sent the person for a diagnostic PET-CT, and of course, their continuing follow-up. So here is the data. This was done at Geisinger by Hopkins investigators in combination with Thrive. 10,000 women. The test looked at 16 mutations and 9 proteins. On the initial screen, about 5% were positive. Then they ruled out CHIP. They insisted on the identical mutation, and they ended up with 1.4% of people being a true positive for their purposes. Now, 26 cancers were found. That's the true positive for cancer, and 101 were false positives. That wasn't all the cancers that were detected, however. 24 cancers were detected by standard of care screening, that is mammography or colonoscopy, that kind of thing. But 46 cancers were detected by neither methodology, meaning that the blood-based test only detected 27% of the total number of cancers that were found in the population. Here is a schematic showing the cancers that were found by the blood test. You see some lung cancers, some ovary cancers, and some other scattered organ sites. This is the total number of cancers in the panel B. You can see the green are some screen-detected cancers, And the gray are cancers that were found in the course of clinical follow-up and care. Now, when one looks at the stage of cancers detected by blood cancer screening, you see many of them are advanced stage disease. Now, that's not so surprising because this was a prevalent screen. That is, you just went into the population and looked for cancer incidence. However, we do see some early stage cancers detected by the pan-cancer blood test. What about the false positive burden? The 101 people who had a positive test, what happened to them? Well, about 60% or so were felt to be done. They had the PET CT or clinically, and they felt there's nothing more need to be done. 16% required some additional non-invasive testing like an X-ray, a CT, an ultrasound. 19% required something a little more than that, such as a scope or a hysteroscopy. And then there were 3 people who had surgery, but you could argue that those surgeries were really necessary surgeries. They found important precancerous lesions, such as a large high-grade dysplasia lesion in the colon that couldn't be removed endoscopically, or an in situ cancer of the appendix. So when we go back to the original questions that were posed, can the multi-cancer blood test detect cancer? Yes, it can. Can it intervene in cancer progression? Well, it's suggestive by those early cancers. Of course, we don't have a control group to compare it to. Yes, it does not interfere with standard of care screening. And perhaps most importantly, it does seem to be able to be performed safely without incurring a lot of dangerous workup. So 2 observations I want to make on the DETECT-A trial. The first is these tests are all geared to have very high specificity. But when you're looking for a low prevalent thing like cancer, it means that most of the positive pan-cancer blood tests will be false positives. And I'd like to emphasize in terms of sensitivity, fully 48% of cancers were not detectable by neither the blood tests nor standard of care screening. So in conclusion, blood-based biomarkers certainly have the potential to screen the unscreened. They have the potential for multi-cancer detection. We are still in the very early stages of determining their efficacy. Thank you.
Thank you very much for this very clear and complete presentation. We will just move to the next one and we'll have the question after that. Our next speaker is Carlo Signore. Carlo Signore is from Torino in Italy. He's also very well known from our group as a main leader on colorectal screening in both Italy and Europe. And is very involved in most of the good randomized controlled trial from this country and from Europe. So we are very pleased to learn more about the design of the new trial. Thank you, Carlo.
Thank you, Robert, for the presentation. Thank you for inviting me. It's a pleasure to be here. I have no conflict to declare. Sorry, there is some problem with the... There are a problem with the...
For us, okay. It's okay.
Okay, that's... but that was... well, the randomized trial having mortality as a endpoint are considered the gold standard for assessing the effectiveness of the screening method. But the WHO expert group on the evaluation new screening test proposed a new framework for evaluating new screening test for colorectal cancer in specific. And following this framework, the adoption of a new screening test requires evidence of effectiveness relative to proven comparator test following a phased evaluation process. The cancer-specific mortality is not essential as an endpoint, provided that the mortality benefit of the comparator has been demonstrated and that the biological basis of the detection is similar. We have 4 phases. In phase 1 and 2, the focus is on the accuracy of the test, and the test is offered together with the standard test to people with symptoms or also to asymptomatic patients. while in phase 3 and 4, the focus is on the comparative effectiveness, comparing the relative performance of the new test as compared to the standard one in a screening setting. The need for the comparative assessment and the prospective and cross-sectional assessment in a screening setting is related to the fact that the screening impact is the result of the test characteristic, the positivity threshold, and the screening interval, and also on the acceptability of the test. We have seen in the previous presentation that we have several blood-based screening tests. Some of them are focused on the detection of specific cancer, in particular colorectal cancer, and others have been developed as a multi-cancer test. In any case, for each kind of test, a preliminary assessment of the characteristics is needed. The new test must meet established laboratory standards in terms of analytical validity and reproducibility. And the early assessment of the diagnostic accuracy of the test in the population where it is intended to be used may be justified to address spectrum bias. State distribution and possible biological characteristics are different among screen-detected cancer as compared to clinical diagnosis cancer. And so the predictive role of biomarkers might be different. Therefore, case and control should be ideally recruited in a screening population. We have two main aims for the evaluation: the diagnostic accuracy measured against a reference standard using a cross-sectional design, and the clinical utility, where we aim to assess the effectiveness and harms over the spectrum of the disease using a prospective design, using a study sample which is representative of the population where the test is intended to be used. Coming to colorectal cancer screening test, we may use this as an example of how we can implement a phased approach to the evaluation of new tests. Here we have two comparator tests: the FIT test, a fecal immunochemical test, which has been established as the new standard, as several randomized control trial comparing FIT and guaiac-FOBT, show that FIT has a better sensitivity for colorectal cancer and better capacity to detect advanced adenomas as compared to guaiac-FOBT. The test needs to be repeated, but there is evidence that repeated testing can improve detection and possibly also sensitivity, in particular for advanced adenomas. Sigmoidoscopy has been indicated as a comparator for tests aimed to detect pre-invasive lesions that can be offered at long intervals or once in the lifetime. The cutoff of new tests should be flexible. In fact, the demand for endoscopy resources, which is related to the positivity rate of the test, represent one of the main determinants of the sustainability of the program. And therefore, the possibility to modulate the positivity cutoff to match the local endoscopy capacity would represent a requirement for a new test to be considered for inclusion in a population-based screening program. Therefore, performance of the new test should be measured simulating different cutoff levels, focusing on the positivity range of established population-based program. We can implement pair testing within ongoing screening programs. We can offer both the standard and the new test to all subjects undergoing screening, and we can refer for colonoscopy assessment all subjects who are positive to the comparator test, and also to those testing positive with the new test, or eventually or a subsample of this subgroup, to minimize the potential negative impact on participation in ongoing programs, and also to avoid an excess increase in the colonoscopy demand. Then parallel studies would then be needed within the phased approach to assess participation and to gain further information about the relative performance of the new and the standard test in the screening setting. As already reported from studies assessing the comparative effectiveness of new tests for other screening sites, for example, digital tomosynthesis against digital mammography or HPV testing against pap smear, the prospective evaluation over 2 screening rounds can already provide meaningful information. The outcome of interest in this case would be the detection rate of cancer, in particular state distribution of screen-detected cancer at first and subsequent screening, and eventual interval cancer. the detection rate of early stage lesion is the goal, but the screening may increase the detection of indolent lesion. And we can expect a more favorable stage distribution or a reduction in the absolute risk of late-stage disease among subjects with previous negative exam if the test can detect lesions at higher risk of progression. And similarly, we can expect that a higher detection rate of cancer at screening might be associated with a reduction in the interval cancer rate. And these all the studies by Jim Ellison comparing different fecal tests is in fact showing that FIT can be superior as compared to GUAIC-FOBT, as the increased detection rate at screening is associated with a substantial reduction in the interval cancer rate. When coming to multi-cancer test, we can imagine two main scenarios. The test, the new test, the multi-cancer test, can detect cancer for which a validated screen test is available, for which you have a standard of care screening. But the test can also detect cancer for which no proven screen test is available. So we have two different situations. If the test is detecting cancer for which we have a standard of care screening, then we can use the phased evaluation approach that we have already described for colorectal cancer screening test. And we can have a comparative evaluation of the new screening test to the established screening test, let's say mammography or PET spiral CT for lung cancer, for example. And we can run, for example, cross-sectional studies to compare diagnostic accuracy of the new test as compared to the standard one using, for example, paired testing. We can also consider additional aims. For example, we might aim to assess the potential increase in the population coverage when offering blood tests to non-responders to standard of care screening. And also, we can use a different approach. We can eventually consider using the multi-cancer test as a triage test, as an example, to orient management of screen-detected lung nodules at spiral CT screening for lung cancer. If we are instead having a test which is detecting cancer for which no validated screen test is available, then as stated also by the authors of the DETECT-A trial, we cannot be certain that our screening could help any patient in the study. In this case, the phased approach is not applicable. And again, we might need to go back to run a randomized trial having mortality as an endpoint. This can be just an example of which could be the target population of this trial, that is people who are eligible for colorectal, breast or lung cancer screening, that is standard of care screening programs. And we might eventually consider randomizing these people to an intervention group where we are offering both the blood test and the standard of care screening. And all people testing positive to any of these tests, including the blood test, would undergo assessment, including PET-CT imaging or the additional diagnostic assessment which are associated with the performance of the standard of care screening test. And we might have a control group, usual care, or where people are offered just the standard of care screening test, and they are managed based on the result of the screening test. The blood test might be performed, but the result might not be disclosed, and it just used for the follow-up assessment. Intermediate outcomes in this case might be the stage distribution of cancer detected in the blood test group and the usual care group, those who are not detected by standard of care screening, and also the incidence of cancer not detected by standard of care screening programs might be considered, might be evaluated and compared across the two groups. In this case, for example, the risk of overdiagnosis might be considered, in particular, for example, for thyroid cancer, which there is strong evidence of high risk of overdiagnosis. sorry, there is problems in the flow of the slides. We have some open issue. The target population should be defined. We might target average risk people, but also we might consider targeting high-risk subjects, in particular, for example, subjects with hereditary syndromes, which are at risk for the different type of cancer. We need to define the screening interval for blood tests, and we have to find a way to integrate the standard of care screening with the multi-cancer screening approach before running these kind of studies. We can take advantage eventually of the organized screening program platform to implement this comparative effectiveness research. The framework of learning programs adopting a randomized design to assess the effectiveness of changes within ongoing established programs might facilitate the comparative assessment of new technologies. And also it might be useful to implement longitudinal sample repositories, biobanking, integrated with risk factor data, which may accelerate the new development of new cancer screening technology. I would like to thank for comment some colleagues and friends, and also thank you all for your attention. Thank you very much.
Thank you very much for these talks on a very timely topic that's getting a lot of attention. We do have a couple of questions. One for Dr. Schoen from Dr. Gupta. I had major concerns regarding the design of the Lenin trial, that's the THRIVE trial, including the potential for verification bias, problems with differential follow-up to learn what the true state is and how discordant tests were handled. What was your take on the quality of study with respect to avoiding bias? And in general, how well is this field using high quality study designs? Rocky, do you want to give that a crack?
Sure. I thought the THRIVE trial was a very well done study. I thought they very cleverly, again, there was a great concern about specificity, about sending people through with workups for a mutation that doesn't turn out to be a real finding. So they established some threshold positivity, and they went through that. Incidentally, they were very clever. They didn't bring everyone back. They only didn't bring people back who had a positive test. They also brought back a sample of people who had a negative test. And in fact, you didn't know when you were called back, whether you were called back because you had a positive or a negative test. So they definitely did instill some rigor in that regard. The population is still under follow-up, and they're in the Geisinger system, so that's a nice way to get long-term cancer incidence.
Rocky, I would add, though, that in both the GRAIL and the THRIVE studies, that sensitivity was not stated as a goal. Specificity not hurting people was, and for us in the colon cancer screening business, we want a high sensitivity test like a FIT or Cologuard or whatever, a non-invasive thing, so that if it's negative, we don't have to do a follow-up test. That's one issue in metrics that I think at least ought to be on the table to consider. There's another question for Rocky, and I think Carlo too. I'm curious about how blood tests can be of help for detecting non-invasive superficial lesions, such as adenomas or serrated polyps. They don't make much signal. Are you optimistic at all about having a blood test for these kinds of lesions that you say are important?
That's an open question. The beauty of the Freenome study and the Garden study is that they are, comparing blood tests to colonoscopy. They will have plenty of advanced adenomas with which to see how their blood test operates. And we should get answers on that, when the studies report in the next year or two.
Do you have any feel for preliminary data from Garden or Freenome from what they've published about sensitivity for those lesions that aren't cancer, but that we think are important?
There was an abstract from Freenome I believe it was at one of the cancer meetings that said that they had a detection rate for advanced adenomas. I believe it was in the 40s%, but that's not a prospective study, and there's certain issues with that. So I think we really need to see how it operates in the clinical trials.
We do have a question from Girish Pusha about what should the accuracy of the tissue of origin be, the tissue of origin test. It said this is outside of our range in colon cancer, but if you're doing a multi-cancer test, how accurate does naming the right cancer need to be? This is going to be a big concern to FDA and everybody else.
I don't know, maybe Carlo wants to take a shot at that first.
That's a difficult question anyway. I mean, of course, I mean, it would be important to have some, at least some indication based on the test result of to prioritize the assessment that you are going to implement or to suggest or to recommend to the patient. And that would be definitely important, because otherwise you would need to have a very broad range of tests to improve, to implement or to perform. So it's difficult to have a specific target, but I mean, ideally it should be high target because it would be important to orient the management of the patient to avoid unnecessary examination and to avoid exposing the patient to risk of side effect.
Last very brief question for both Rocky and
I'm sorry.
Go ahead.
Yeah, I'd like to add to that and just say that it's incredibly important to have the longer term follow-up, let's say from Detect Day. For example, what about the people who tested once positive and then the repeat were negative? You'd certainly like to know what happened to them from a cancer standpoint going forward. Certainly the people who had a PET CT and were felt to be okay, what is their long-term natural history in terms of cancer compared to the rest of the cohort? So a lot of this is following people for sufficient time to understand outcomes.
Last very brief question for both Carlo and Rocky. Neither of the multi-cancer tests, the major multi-cancer tests, GRAIL or Thrive, is making a claim now about standard of care tests. They're saying, we've got great tests for those. We're not trying to take their place. Like colon cancer screening or breast, do you really think that a multi-cancer test with its current performance characteristics and what might be in the future, is this really going to end up being relevant for us in the colon cancer screening business?
Well, it might be relevant if we can show, for example, that it can detect at least cancer, maybe not advanced adenomas, but at least cancer, possibly at early stage, at the same amount or even better than the existing test. Or, of course, as compared to colonoscopy, you can use the relative sensitivity using FIT as comparator. But in this case, it might be a complementary test, because we might discuss about the acceptability. There are people refusing FIT or because of difficulties in ending feces, and they might be more available for a blood test. So in this case, you have a complementary test and you might offer it to improve the coverage of screening, and it might be an option. Otherwise,
I would strongly...
Rocky, any last comment?
Yes, I would strongly second that. We know that a lot of people won't do a stool test and they won't do a colonoscopy, and they may go and get a blood test. So in terms of bringing people into the process, it has great potential.
I think the question is it ever going to perform well enough to be competitive? And that remains to be seen. I think we're at the end of our hour, and want to thank the speakers and the audience. And Evelien, time to turn it back to you.
Thank you so much, David, Rocky, Carlo, Robert, for this last session. That was, like all the others, very interesting to me, very challenging. I would like to thank all the presenters of all the 4 sessions to share their knowledge and also their experience with us and debating with us. As always, we have too little time to do debate, which is better anyways in real life. So I really hope that the next DDW meeting will be lined up for us as well, so we can also have a live WEO meeting at that time. So I also would like to thank the attendants, the participants, also for their discussions and their questions. And of course, I would like to thank all our sponsors. Here are the most important ones of today for this CSC screening meeting. We are very indebted to them. This is just a webinar, but very important to us. That's why I really would like to thank them, because without such support, we wouldn't be able to hold such webinars either. I would then, I know Alexandra is already putting up the next slide, but there's of course 2 other people that I need to thank that are not on the slide, but that's first of all Alexandra, because she's been doing a great job in organizing not just the meeting of today, but also all the webinars that we had in the past weeks. That I thought were very well organized, and I really have to thank her for doing that in such a professional way. And of course, the same accounts for Ruth Baksh, that we all know all for so long. I also thank her very much for all her work she's doing for our committee. This is about the coming up meetings. We will, first of all, we will send you a survey on this meeting and also on the webinars we had of the expert working groups, because we value your opinion and we would like to hear your opinion to know what would have your most support to do the next half year, because UEG week regrettably won't have also a live meeting for themselves, neither for WEO, of course. APDW, that's on the list now, is going to be virtual. The WEO meeting is on the morning of August 19th, actually for Europeans at 4 a.m. in the morning. I will be there. I hope some of you might be as well. And I hope at least we will see many of the colleagues from the Asian Pacific that regrettably had a difficult time to join us now. So the plenary meeting in October will be again a webinar. We have a provisional date, which is Thursday, October 1st, but again, Friday, I apologize, Friday, October 1st, but we still have to do some alignment with the meeting. So we will get back to you as soon as we know. There is, of course, May 2022, a Kyoto meeting, which is the large WEO meeting. So not just from the CRC screening group, but the whole of the World Endoscopy Organization. And then, of course, we hope for DDW live in San Diego in the US. I hope you will stay connected with us. As I said, we value your opinions, your ideas. Please feel free to suggest colleagues and enthusiasts to be added to our list. Here you see the email address. You probably know it already, but please let us know who else would be would like to be in our membership. We would like to also know your suggestions for topics for the October meeting, and we will send that an email on that to you as well in June. And do you want to contribute to anything of this committee, any of the activities or any other active participation? Please let us know your ideas. So thank you very much for attending again today. I had a great time. I hope you have had a good time. I hope we will see each other live soon in the future. I wish you good luck, stay safe, and see you again. Thank you.